I can't see if we've got everybody that we would hope to have from here, so I'm going to...
David, just to let you know that we're live now.
We are live. Okay, well, good morning, everybody. Welcome to this joint meeting of the Overview, Scrutiny and Health Committee on Thursday, the 16th of July at 10 a.m. I am required to make a short announcement in relation to the way we're holding this meeting. Attendance at this meeting, due to the coronavirus pandemic, the council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the council's website for them to do so. Members of the council are asked to keep their microphones and cameras switched off until called to speak, and switch their microphones and cameras off once they have finished speaking. To indicate a desire to speak, members should request to do so using the public chat function. I will ask in due course for members to vote for, against or abstain for each item at the end of the debate on that item, and ask that members indicate their vote using the public chat function. I will declare the result after each vote. Officers are in attendance, but will keep their cameras and microphones switched off unless called forward to speak. Okay, well, thank you very much. There are some membership changes. We welcome Councillor Maggie Parker as the newly elected representative to Health Scrutiny Committee for Watford. Welcome, Maggie. We have apologies from Alex Binder of Decorum and one of our public representatives, Natalie Punter. So, could I ask members if they have any interests they wish to declare? I take that as a no. Thank you very much. With regard to the minutes of the two relevant previous...
Sorry, Chair. I did the chat share an interest. That's the way we were operating this morning. It's Roma
Hello,
Mills
Roma.
speaking.
Yeah, sorry, got you, Roma. Yeah, hang on a second. Hang on. Yep. Okay, yes, sorry, it was a bit slow coming through on my screen. Roma, yes, please, would you make a declaration?
Yeah, thanks very much. It's not a pecuniary interest, but I think I should declare that I've been invited to attend meetings of the Mental Health and Learning Disability Integrated Care Partnership in relation to my employment, and I've attended 2 such meetings, and that partnership is referenced in the paperwork from Hertfordshire Partnership Trust. I don't think this impacts on my ability to take part or vote. Thank you.
No, thank you for that. Many thanks. And any others? I'm just looking at the chat function again. Nothing's coming through. Okay, thank you very much. With regard to the minutes, we've got 2 meetings to consider the minutes of, but under the circumstances, would you agree that we consider those at the most appropriate time, which would probably be the meeting of the Overview and Scrutiny on the 9th of October and Health Scrutiny on the 30th of September, the minutes being the committee meetings held in January 2020 and March 2020. My proposal to you is that we consider those at the appropriate OSC and HSC a little later in the year. Can we have agreement on that?
Agreed.
Thank you. In the chat, please, if you would. Okay, I think we can accept that. Okay, many thanks for your support on that, members. Before we go forward, there are no public petitions, and before we go into the report itself, can I just take a few moments to explain what I hope we will do this morning. You'll be aware that this is our first scrutiny meeting to be held virtually, and being a meeting of both committees, the membership is considerably larger than usual. Could I ask you to notify me of your wish to speak via that chat function, as we've already tested, and you will be muted until it's your turn to speak. And if we stick to time, we should be done by about lunchtime. I think it's really important just to remind you, so we're all clear about the purpose of this meeting. The purpose of this session is for the scrutiny committees to gain an overview from the Council and the NHS of the impact of COVID in order that we may better plan and prioritise the scrutiny work programme for this autumn and beyond. We're basing our approach on that outlined in the statutory guidance published last year by the MHCLG. It regards evidence sessions as a key way in which scrutiny committees can inform that work. Therefore, with your assistance and the chairman of HSC and I ask that we focus on evidence gathering and the questions of clarification that we might gain an overview of the response to COVID, its ongoing challenges and plans to resume any council and NHS services that have been disrupted, manage backlogs and return to the new normal. After gathering evidence at this meeting, we can then decide which key areas to focus on for an in-depth scrutiny in the autumn, either at future committee meetings or in topic groups. So please, let's all work together to achieve that aim this morning. We've got a lot of work to cover. So I will ask, no further ado, I will ask Natalie to introduce the report. Natalie, would you?
Hello, everybody. Just to reiterate what the chairman has said, we've tried really hard in briefing the presenters today to focus in on what the impacts have been and what the likely scenarios are moving forward. So just to reiterate, it is about gathering information so that both committees feel equipped to prioritise by the end of this meeting at least the areas that they would like to undertake further scrutiny, and give perhaps officers a steer in terms of which kind of activity they'd like that to take place, either committee meeting or topic group. And then that will enable Fiona and I to approach colleagues at HCC and more broadly to get those scrutinies underway, so that by the autumn you can begin to undertake scrutiny activity in the way that we did prior to the COVID outbreak. The services were asked to provide short bullet points against three concerns about what their concerns had been during the early stages of COVID, what their current concerns are and what they are going forward. The chairman has asked that I just give you a quick summary because there was a lot of commonality across those concerns, particularly the current concerns and going forward. So I'll just state what those appear to be, because I do believe that this would be helpful in terms of where you might want to focus your questions to presenters across the board. So obviously one of those which emerged across many services was around inequalities, and that's health inequalities, education inequalities, including SEND and for vulnerable children and adults. The second one that emerged very strongly was the impact of a potential second wave in terms of preparedness for that second wave, alongside increased demands. As we know, the health service and social care services face pressures during the winter anyway, and if a second spike occurs at that time, that will be a compounded issue for services across the board. Then there are the economic impacts for employment, for businesses, for the authorities themselves, ours and other local authorities, in terms of the spend and the cost pressures which have been encountered in addressing COVID requirements. And the final bullet that I think will come as no surprise to anybody sitting around the table is the backlog which has occurred for both health in terms of cancelled appointments and also referrals being quieter from children's services and adult care that will emerge once services resume to something like normal. And this could be compounded with increased demands. The HPFT paper, for instance, does talk about an expectation of increased referrals that are a consequence of pandemic. So those four bullet points are inequalities, second wave, economic and finance, and the final one, which is backlog. That's all I had to say at this point, Chairman.
Excellent. Thank you very much, Click my microphone on. Right. Excellent. Thank you, Natalie. Okay, colleagues, we now have to launch ourselves into the, having excellent introduction, launch ourselves into the to the main business of the report. We are going to, just with the housekeeping, we're going to cover it in the order public health with Jim McManus, children's services, which will include education, from Jenny Coles, and ACS from Ian. After that, we will take a short, well-earned comfort break. So I anticipate that'll be about 11:15, 11:30. So with no further ado, is Jim McManus in the room?
Indeed, I am, Chair. Thank you.
Ah, wonderful. Good morning, Jim.
Good morning.
Thank you for taking the time to see us. I know that you are at the very at the very forefront of much of the work that we are doing, and we're very grateful to you. Could you start your presentation? Thank you.
Yeah, thank you very much, Chair. There's if I group what I'm going to say into three things and I've been asked to be fairly brief and take no more than 5 minutes, I think, which is the rule for all of us. The first set of things to say is that public health have been doing a number of things from prevention through to response and support in the pandemic so far. That has ranged from delivery of funding and resources to some people to providing project managers. So, for example, every work stream of the major incident programme, we provided a project manager to. So the project manager for the Sustain operation and the Shield operation was from us and various others. We stood up a helpline for schools and a variety of other things, which I won't go into the detail of because they're in the report. The information and intelligence and the modelling, and we've prioritised the modelling to enable the strategic coordinating group to respond. So things like modelling bed numbers, collating data on cases so that we can model the resources we've needed. And I believe that's had the desired impact of it's enabled us to manage the first peak. And I think the third thing has obviously been to engage in prevention, which we worked closely with comms on. During that time, we reprioritised in accordance with national guidance our public health services. So a number of services were turned online only, although we kept mental health services for children and young people, particularly through school nursing going, and we moved a lot of services online. A lot of sexual health services were moved online. We're now in the process of standing those services back up, but some services like drug and alcohol services that are needed to save lives continued. So we faced in several different directions as a function. It's fair to say now as we move out of the first peak, we're still doing that. And to move on to the second section of things, we now have an outbreak plan which has been published, which identifies actions to prevent and control infection in care homes, schools, high-risk settings, vulnerable communities, and a number of other themes which are themes government has decided upon. That plan's public. There's a multi-agency health protection board in place. The care homes plan is already in place and working. The schools plan is already in place and working. The testing capacity is already in place. We have new testing capabilities coming on stream as of the 1st of July. And we are working on that. So one part of our directorate is still working on COVID response, even as the council is looking to move to recovery. And the rest of us are looking to move to stand up services and look at what that will do. And that brings me on to the third set of issues, which really is moving to recovery. As we move over the next 3 months, 6 months, 12 months, I think we will have several priorities. The first is to prepare for a second peak, which remains possible. The people of Hertfordshire have been utterly amazing through this pandemic in the way they have complied with measures. I mean, they really, really have. and we have to recognise that. Sadly, we need them to keep going because we don't have a vaccine yet. But we need to prepare for a second peak because it remains entirely possible that we will get one in winter. That means that while we're trying to recover and stand some services up, we need to continue our efforts to be ready for winter. So ensuring that flu vaccination and other vaccinations are taken, that winter demand readiness is planned for, so we don't have staff off sick with flu at the same time as we might have a COVID peak. That is really going to be crucial for us. The second thing is, I think we need to understand as we move beyond winter into the next 6 to 12 months, the multiple impacts of COVID. So there's a grief impact from people who have sadly lost people. There's a mental health impact. There is a significant impact of people whose health is not as good as it was going in, and we have to work hard to get our population to be as healthy as we can do. That's a job for everybody, NHS, non-NHS included, and we need to work on that. And then I think the final thing is COVID has hit hardest those who were least able to bear the burden. So inequalities has been writ large nationally and internationally on COVID, and the same in this country, including BAME populations as one important strand of that. That does mean, I think, we need to think about what we do going forward in terms of our plans to address those inequalities and ensure that the people who've been hardest hit have the greatest gain and recovery in their health, as well as the social determinants, things like employment, education, and so on. So that, I think, is a big agenda that I've set out in 5 minutes, but I think my colleagues are fully seized of it and are working on it. And on that point, I'll stop there, Chair, if I may, and happy to answer questions.
Thank you very much, Jim, and thanks for the excellent work that went into your submission in writing. Thank you for that. Right, I'm going to put it over to members now. I have in the following order: Nigel, Margaret, Ron. I've got others, but that's what I'm taking for the moment. So, Nigel, would you start us off, please?
Thanks, David, and thank you, Jim, and congratulations on what you've been doing. I know how hard you've been working, and it's very, very much appreciated. Couple of points. I mean, your point about health inequalities is very well made, and particularly in your bullet points, it stood out very clearly. And I don't know if you can say anything more about how we take that forward specifically. I'm still concerned, as you know, about the testing data and our preparedness for test and trace. If you can comment a little bit on that and how that can be improved. You mentioned the compliance of the local population, which I agree has been very good. My observation is that we are beginning to lose that now. In my own circles, I've seen as cricket clubs start again, really not that serious compliance with the 1 metre plus, not necessarily on the field, but just off it, and equally in the community, in shops and so forth. So how do we keep on top of that and improve the messaging? I know that's a national problem as much as anything else. And the last question is the impact of the redeployment of staff and whether that is going to be a big issue. I know you've kept some services going, but others have stopped. How are you going to juggle those balls basically going forward?
Sorry, I was on mute. Thank you very much for saying that. In terms of inequalities, I think it requires all of us to do our part, but my roadmap would be we do a thorough assessment of where we think the inequalities and the impact has been with the information we have to hand. But there's action for everybody. So if you look at the Money Advice Service, they're working on this in terms of COVID. We've started asking all our public health services to look at what they can do. I think there is a job with the NHS for primary care to kind of go through and risk stratify people on their register who may be most at risk in a second curve, and also who have been impacted now, and look at measures. So there is something systematic for every single agency to do, and we need to sit down and identify that. Improving the physical health of people who've been shielding, I think, is another area. So we're working up a list of impacts and things that we're doing, and happy to bring it to future meetings. I think it will come to Cabinet panel anyway, and there's work for the ICS, which I'm sure Jane would agree with. So I think that's a huge agenda. In terms of testing data, I am told that Pillar 2 data, so we were getting Pillar 2 data, which is the non-NHS testing weekly postcoded. I am told as of this morning it is due to flow in daily, but then we were told that last week by the Joint Biosecurity Centre, and I think there have been problems. So it is improving. It's not perfect, but it is improving, and we're getting better, so we can do more with it. In terms of compliance, I agree that it's slipping with some people. So we will be launching a public campaign soon, particularly aimed at, the reason we take these social distancing measures is not to protect ourselves, it's to protect others as well as ourselves. So we are working on that, and there will be a number of things launched over the summer to support people with that. And finally, in terms of redeployment of staff, we are standing back up all of our services as much as we can. If you take the example of the school nurses, we will have to do testing in schools if we have outbreaks. We're not having the school nurses do that because we think it's more important for school nurses to be school nurses. So there will be additional testing services doing testing in schools, not detracting from the really important work school nurses will be doing, but by way of example. And sexual health services are being stood back up. Drug services are being stood back up. We've actually put more work into smoking cessation. I think the psychological impact of redeployment of staff is going to be quite key. Public Health have paid for post-traumatic stress training and wellbeing champion training in care homes with Hearts Care Providers Association, and it'll be interesting to see how well that goes, because if that does go as well as colleagues in ACS and HCP think it does, we may have a model that we can work with for the rest of the system, because there is quite a lot of stress in care homes, but there's also quite a lot of stress in some of our nursing services.
Excellent. Thank you very much, Jim. I'm going to call on Margaret now. I would just mention beforehand, I've no desire whatever to restrict questions nor indeed answers, but I'm only allowing another 8 minutes for this session. So please keep your questions and answers as brief as you may. If you have questions that you don't get to answer, would you please capture those, because we can look at them later and possibly feed them into our thinking. So please don't throw them away. Capture your questions if you don't get to ask them. Thank you. Margaret, over to you.
Thank you, David, and thank you, Jim, for that clear presentation, especially about Pillar 2 update. I did send you some questions in advance because you mentioned stress in care homes, but there is also quite a lot of stress in schools as to how protected they really are. And I was thinking the messages and training for school staff to be giving out the right messages is something that would be really helpful, and I wondered whether you were doing anything to train school staff ahead of time, for instance, in August. And particularly, you've just mentioned you're putting in extra staff for that aren't school nurses for testing should you find there was an outbreak, or 2 or more children, or even one child if they mention their family has got it. I was going to say, what advice do you then give to the head teacher? So question 1 was really, could the school nurses be used in the education of staff especially, and helping schools to be the place for giving out the right messages and to try to stop panic and to try to protect our community. And then the second question was to do with actually accountability of the Pillar 2 statistics and what happened in Leicester and what happened in Anglesey, and trying to get quicker reporting for, well, everywhere really, but because Hertfordshire, and you've got both you and Jane Halpin able, I hope, to get more accountability and, if necessary, respond to government actually in getting those statistics for the safety of our community. Those are my two questions, really. Thank you.
You're muted, Jim. You're still on mute.
All right.
Sorry, I was having trouble unmuting myself there. It seems to have a mind of its own this morning. On schools, we have an outbreak plan for schools, which is run jointly with Children's. We will do an education campaign for schools. We already have done some campaigns. There is a protocol for testing. The reason I don't want school nurses doing testing is because they need to focus on improving the health of our children, not spending the next year being reactive and doing testing. And I think that's and actually our colleagues in the providers have been important in identifying that. Yes, we can do preventive work with them, and that will be part of it as part of education, as part of their workload going forward. In terms of testing accountability, all I can say is that we continue to work with the Joint Biosecurity Centre to get the data that we can, and I think it has moved. We are doing analyses on the data that we've got. I'm not quite sure what else I can say really on that one, other than we continue to work with them.
Excellent. Thank you, Jim. Ron Tyndall. Ron, are you there?
Thank you, Chair. Thank you,
Morning.
Chair. Jim,
Morning.
very short. Page 37, at the paragraph 5 at the bottom of 4.1, it says proactively people who will be most adversely impacted. Can I assume that what we're talking about are vulnerable people with preconditions and things like that, who will need to be continue to receive shielding services and things like that, or does it mean something else?
I think it means a variety of things, Rob. So firstly, it means people who are in the category you've just mentioned, but also there are people who may be far more exposed to the virus because of the nature of their job. And so getting every employer in Hertfordshire to be COVID secure, to use that term, is actually really important for inequalities. Making sure that every nurse and every care home worker gets the PPE they need, so that they are, particularly if they are vulnerable and have pre-existing inequalities, doing the right levels of risk assessment for workplace staff if they have got vulnerability factors. So there's a variety of work that goes in there to do that. Happy to give you a more detailed briefing offline if that helps.
I think possibly the committee might welcome if you could give a more detailed briefing at some stage when it's convenient, Jim. I know you're very busy, but thank you very much for everything all of you in public health are doing. Thank you.
Thanks, Ron. We are approaching the limit that I've imposed on this session, but we do have time for one more. So I'm going to invite Roma to ask for any points of clarification or questions. Fiona and Francis, I'm conscious that you've asked. Not able to permit that just now, but as I say, if you would be good enough to capture that. And as an aside, Richard Take, would you turn your camera off, please? If you only have your camera switched on when speaking, that would assist the process enormously. Thank you. Roma, over to you.
Thank you, Chair. and again, appreciate great leadership the public health has given us in a time of crisis, and that's so appropriate in any case, but really thanks for that. Very encouraged to hear Jim talk about the need to prepare for a second wave, because I've been asking about this persistently. And I would like to also be reassured that, yes, we obviously see the people who are particularly vulnerable to the virus itself, people from the Black and Asian minority ethnic community, people with existing comorbidities, people with particular conditions. But I'm very, very concerned about those who have been affected by the way we've had to respond, by the lockdown, by the social distancing, by the isolation from family. So people in coping at home, perhaps with a very ill or disabled husband, wife, or child, with the normal support and service structures withdrawn. And I want to make sure there's a particular focus on those people, because I think the thought for them of going back into lockdown will test their resilience unreasonably. Thank you. That's the reassurance I see.
I agree. I think the thing we want to avoid at all costs is a repeat of the March lockdown. It worked enormously, but it came at huge cost. It was not a cost-free thing, as you say. If there are particular communities and populations where we need to act, I'm happy to look at what we can do. So if you take, I know it's not the immediate community you're raising, Uma, but if you take older people who have lost muscle tone because they've been shielding and not able to get out, one of the things we're looking at doing is whether we can use voluntary sector and physiotherapy and other services to go in and do specific safe visits to them, to get them to be as independent as possible so their quality of life can improve. And Ian and colleagues have been working with that. If you look at BAME communities, so Faz and Alex, who work to Scott Crudgington, have been doing a huge amount of work on this. There is obviously more that we need to do because this will impact everybody. So happy to look at doing what we can and prioritise people. And I agree that I think we do need to look at how carers particularly have been impacted by this.
Thank you very much, Jim. In closing, can I thank you? You have heard some comments from members, but I'm sure the committee would want me, both committees would want me to thank you and ask you to pass that thanks on to your team. We know you have a large team. This is a complex process, constant challenges. We are extremely grateful to everybody for the work that they're continuing to put in. Thank you very much.
Thank you.
Thank you. Committee, we're now going to move over to Children's Services, and they will be represented today by Joe Fisher and Matt Ansell. Could they make themselves known? Hello, good morning, Joe. Hi, Matt. Good morning. Okay, welcome. We're more or less on time, I'm pleased to say. So that takes the pressure off you a little. So a very, very good morning to you. Thanks for joining us. Again, we're all very conscious of the hard work that's going on, and we appreciate your taking the time and trouble to come and see us. Would you, I don't know how you're going to manage this.
Okay.
Are you a practice double act?
Yeah. I'm going to lead on just giving an update around safeguarding services. Then I'll hand over to Joe, who's going to cover special education needs and education.
Okay, many thanks. Off you
go. So I just wanted to start by just sort of outlining some of the areas of impact that's been affected around the safeguarding services. So like all local authorities around the country, Hertfordshire experienced a significant drop in referrals into children's social care at the beginning of the pandemic. In April, we saw around about a 45% drop in what our normal referral level would be. That continued into May at around 55%. That has slowly picked up in June and July. We're starting to see sort of referral levels at what we'd expect them to see. They're still slightly lower, but they're certainly increasing. In terms of how we've been able to respond and make sure we've maintained our statutory responsibilities to children and families around our safeguarding services, we've made use of virtual visiting to families, to children looked after. We've we've moved all of our child protection and children looked after reviews to virtual platforms. And by doing that, we've been able to maintain our statutory responsibilities and timeframes. So we haven't had to sort of defer or move away from those statutory timeframes for those important meetings and reviews. What we've also done throughout the pandemic is maintain face-to-face contact with families. So we've maintained our statutory duties regarding visiting children that are either on child protection or child in need plans. And equally, we've continued to visit children that are looked after in our care, either at their foster placement or residential placement. And we've obviously, within that, followed the national guidelines around that social interaction and what safety measures needed to be in place for staff and the families and the children that we were visiting. So there was, in April, the government also issued amendments to what's called the Adoption Children regulations related to COVID-19. And that impacted around 10 areas of existing legislation. In Hertfordshire, we haven't had to make use of any of those changes in regulations. We've, as I've sort of mentioned already, we've been able to maintain all of our statutory functions. We've maintained our adoption panel functions, albeit in a virtual way. And we've maintained our statutory functions around our residential and fostering services. Moving forward, if we start to think about the impact of the pandemic and what it's going to mean for children, families and the communities and the impact on our services, we've done modelling work within the department around what the potential influx of work could mean for us. And the modelling work is built on a number of assumptions, but also modelling what volume of work we'd normally have. And it's taken into account needs of families and the communities of Hertfordshire and the likely unmet needs that build up over time during the pandemic. And within that, we have modelled that we could experience a rise of around 30% of referrals into children's social care. So at the current time, we're working on plans to how we would address that and meet that potential increase of work into the services. What remains paramount within that is ensuring that we've got a strong and effective early help response in order to make sure that families receive support at the appropriate level, and also that we do not unnecessarily burden our statutory safeguarding child protection services. And then thinking about the areas of need that we expect to see going forward, there's a range of them which I think are outlined in the report, but specifically we know that the impact of the pandemic has been around domestic abuse. So victims and their perpetrators have been sort of forced closer together, and we know that national referrals for domestic abuse have increased significantly into helplines. So we expect to see an increase in that area. Jim's already mentioned, but we're focusing really significantly on the sort of mental health and emotional well-being of children, the impact of not being in school, the impact of that emotional connectivity with their peers, and how that will sort of pan through into their presentation when they go back into schools in September. We also are modelling and carefully monitoring levels of homelessness. We know that the government committed to banning evictions for the first 3 months during the lockdown period, but by working with our colleagues in housing departments, we understand and recognise that there could be a significant demand around homelessness and that rent arrears that are built up during this time. Obviously, we are aware that we could be facing a significant national economic downturn, and the impact of poverty on families that we work with and how that relates to childhood neglect is a significant concern for us. So we're doing a lot of work across our safeguarding partnership with colleagues in health and police and the other key professionals to look at our response to neglect and how we'll respond to an increasing level of neglect within Hertfordshire. And then there are other areas of concerns for children and young people and their families, particularly around substance misuse, how the pandemic's impacted on people's levels of stress and anxiety, and families that would already perhaps use drug and alcohol as a way of medicating and controlling some of those issues around stress and anxiety, that would have increased during this time. And then the last thing I wanted to mention was the way that gangs and county line activity has changed during this pandemic, and we're working very closely, and Joe's teams are working very closely with our colleagues in police to monitor that and make sure that we have responses to support and safeguard those children. So that was all I was going to say in terms of an update. Happy to obviously take questions, and then I'll hand over to Joe.
Fine. If I quickly crack on with a very brief overview of our work with children with special educational needs and disabilities, and the impact on them and their families, and then maybe we open up for broader questions. I do hope that's okay. So very briefly, at the onset of this pandemic, the government guidance was really clear that all children should remain at home where safe to do so, with the exception of vulnerable children and those of key workers. And what this meant for children with special educational needs and disabilities is that in the vast majority of cases, they were safe to, and therefore supported to, remain at home, which had the immediate challenge, really, of the impact of on those children and young people in terms of a change of routine, loss of education, health provision that they usually got in their school, but also the impact on their parent, carers, and siblings, which was often quite widely felt, deeply felt. What we did at the outset was work with schools and also parent carers and the young people to undertake risk assessments to determine which children with education healthcare plans should be better supported at home and which indeed needed to be supported into school. And based on that, we put in place a range of support mechanisms, from remote learning and online specialist advice, flexible use of short breaks and direct payments, put in place a send helpline staffed by our education psychologists and specialists, but also a wraparound support from education, health and care providers to really make sure that we were stepping up and meeting the needs, particularly of those most vulnerable children and young people with special educational needs. One of the key challenges at the time, and key changes at the time, was that the government introduced amendments to the SEND law, introducing two key changes. One was some flexibilities around the timescales for undertaking education healthcare plans assessments, so allowing some flexibility outside of the 20 weeks. By and large, we've managed to maintain our 20-week deadline, although we have seen in the past few months a drop-off in requests for education healthcare plans, and that's a trend that we expect to reverse once schools go back in September. And the other key change was around allowing local authorities and health providers to undertake reasonable endeavours to meet the provisions set out for young people in the education healthcare plan. So that might be who provided, or where something was provided, or indeed what was provided. And that was particularly important when we think about some of our therapies and the fact that many staff within healthcare settings were redeployed in the first instance. And for children and young people, it meant that for many, some of their therapeutic provision was paused. But from September, the reasonable endeavours has been unpaused, so we now need to make sure that the full provision is in place moving forward. The flexibility around timelines remains until the 25th of September, but as I said, we've managed to maintain our timelines anyway in Hertfordshire. Moving forward, just to flag some of the key challenges for children and young people and their carers and indeed providers. First of all, the government, as you know, has been really clear that all young people, where possible, now need to go back to school. And this raises particular challenges for children with SEND. We're working with schools at the moment to make sure they've refreshed their risk assessments to identify what additional support children and young people with SEND need in order to make a successful transition back into school. Some of the key highlights, bubbles in special school settings is especially difficult, particularly given the need for staff sometimes to administer care and provide therapies. Although the average number of pupils within special schools is lower than mainstream schools. But still, we are working very closely with school leaders to think through some of those challenges. As I said, the reasonable endeavours part of the amendment will cease from when schools go back in September. which means that specialist therapies and other support staff for SEND really do need to provide interventions as usual, whilst minimising contact and maintaining distance as much as possible. And we're working very closely with our therapy providers and community providers across speech and language, occupational health and physio to really make sure they're back on track from September. We've had a lot of inquiries from parent and carers, as you might imagine, around shielding, which, as you know, has been paused from August the 1st, and what that means for children with special educational needs. Most children will return to school. There are exceptions for those who are extremely clinically vulnerable. And again, we're very clear with schools around our expectations that they offer remote learning and education for that small minority of pupils. And lastly, just to touch on mental health and emotional well-being, some pupils who return to school will have been exposed to a range of adversity and trauma over the last few months, and that might lead to an increase in social, emotional and mental health difficulties. And for some children, including those with special educational needs, or indeed those with a social worker, they will need additional support and access to services such as education psychology, counselling, CAM services, to really make sure that they can have a successful and smooth transition back into school. Our CAM services have really stepped up. There's a helpline in place. We've got our education psychologists have produced some great resources for schools around mental health and emotional well-being, and how our school leaders and SENCOs might support children on that smooth transition. But we do know that from September, the partnership between our specialist services, our social work services and schools is going to be absolutely fundamental to make sure that we not only support children back into school, but we support schools to help those children catch up as far as possible too. So that's probably enough from Matt and I. I'm aware of the timeline, but happy to take any questions.
Lovely, Jo. Thank you so much. I'm going to call people in the following order, based on both the position in the queue and also whether they've spoken before. When I call you forward to talk, would you please indicate the area and also who you think is appropriate? If you're not certain who it is, just tell us what the area of your concern is, and obviously Matt and Jo will pick it up. I'm going to call Lynn first. Lynn, would you step forward, please?
Hello, thank you.
Good morning.
Just probably for Matt, because two things I want to talk about are foster carers and teenagers. So Matt, two things that have come out nationally. One, and I'd like to know what the response in Hertfordshire is. One is around foster carers, where nationally there was a report that some foster carers had felt obliged to shield, and so the children had to be found alternative foster carers, or there weren't enough foster carers step forward. Was that affected in Hertfordshire? And secondly, more recently, there is a report out that there are likely to be a lot of teenagers who fall through the gap and then go missing at the end of it. And what are we doing in mitigation of that? Thank you.
Matt, are you there?
Yeah, apologies.
Thank you.
So locally in Hertfordshire, what we actually found during the sort of the lockdown period and has continued actually is our placement stability has improved significantly. So we haven't seen children having to move placements. What we've seen actually is our foster carers, really step up and really support children during this time. So we have had a number of foster carers that have had to shield, but that hasn't meant that children have had to move placements. And we've seen a real commitment to our children looked after by our foster carers and our residential providers, which obviously has been a significant and huge positive thing for us to see during this time. And there's a number of learning points that we're going to take forward into our practice that we've learned during this time. We've got foster carers and children and young people and the residential providers have fed back to us. So in Hertfordshire, we haven't seen that as an issue. And then your second question regarding, second part of the question regarding teenagers, Joe may want to come in on this as well, is we have a really strong offer for supporting teenagers, what we would describe as on the edge of care, so teenagers where there's potential for family breakdown. We haven't seen a significant rise in that at the moment. We recognise that there could be some, extremely difficult family situations that have had to cope during this time, but as of yet we haven't seen a significant rise of children or teenagers having family breakdown and needing to come into the care system.
And just to add to that, Mad's absolutely right. We've also redeployed a number of our YC Hearts practitioners during the pandemic to do detached youth work. So really reaching out to young people who might be on the periphery of services and putting in place support for them. And we've done that in partnership with community policing, which has been really effective. We've had some great feedback from local district areas on the effectiveness of that work. And that report that you refer to, I've read it too, and one of the key things it's flagging as well is the impact on young people in terms of ongoing education, training and employment. And indeed, I think there is a really real risk and real concern out there for young people, particularly those 18 plus who are leaving school and colleges, around employment, apprenticeships and internships, and the lack of opportunities or the reduction of opportunities during this pandemic. I'm aware that the government made some announcements in the last couple of weeks around financial incentives for employees around internships and apprenticeships, and the Kickstart programme, again, really thinking through that sort of job opportunities for young people up to the age of 25 and provision of a minimum wage for up to 6 months, those sorts of opportunities. We're just thinking through in Hertfordshire how we work with the LEP to make sure that we've got a good response both to the government announcements but also to the Hertfordshire picture for our young people, to make sure that we are stepping up and we are doing everything we can moving forward.
Thank you, Matt. Thank you, Joe. I'm going to call Fiona.
Thank you, Chairman. This is either Matt or Joe. It's a point of clarification. I've read the school's testing programme, and could you clarify whether a child or member of staff who has symptoms but tests negative and still has to isolate for 7 days? That's not clear from the plan that I've read.
It might be that Jim wants to jump in on this, because actually that's much more of a sort of public health initiative. But my understanding is that if a staff member or a young person tests negative, then they can return to school. Jim, I think I've got that right, haven't I? If you're still there.
Yes, I'm still here. Yes, if you test negative, you can return to school unless there are additional risk factors that suggest to the person doing the assessment that you might still be infected and should self-isolate. But it's in the flow chart. It's in the school's flow chart that the school's outbreak team have produced.
Thank you.
Thank you very much. Francis, could I come to you?
Yes, you certainly could. Thanks very much indeed. I'm concerned. Thank you, everybody. I'm concerned about the parents of special needs children who have chosen to keep those children at home at the moment. Psychologically, sending them back to school will be hard. We've talked about the support for schools and for the children, but the parents are the very ones who, if things get too fraught at home, eventually could slip into the domestic abuse category, and you need to catch them, of course, before they fall into that category. We've also got the healthy lifestyle issue, because if everybody's at home getting frustrated, they're going to be leading unhealthy lives, and that, of course, means they're more vulnerable. Can you just say something about how you pick up that group?
Yeah, absolutely, and I completely agree with you. I think the impact, particularly on some parents of children with very complex needs and keeping them home it's been very high. We've done a few things. One is that we're working very closely with our parent care forum, Hearts Parent Carer Forum, HPCI they're often referred to make sure that we're getting messages and information out for our parent carers in Hertfordshire. So our local offer has got a lot of information for parent carers, not just about remote learning and education resources, but also those broader social care and health resources too. We've also, our helpline is open to parents too, so parents have been getting in touch with us, and as a response to that, we've put in place some really good wraparound support for parent carers and some really flexible provisions. An example would be that one parent who really just needed her child to be able to get outside safely, we worked with a local school so that that parent could make use of that playground on a daily basis. And it was really quite simple to work out, but it just gave her an opportunity to let her child get that really good, sort of run around time. So there's some great examples of how we've done that personalised response to people. But I do think a lot of this, and it's an ongoing thing for us, is continuing to put out messages and reassure parents about the safety of returning to school. We've put a leaflet out for parents through our schools, giving them some key information around supports on offer, and people are making use of that. So I hope that answers your question, but I agree with you. I think the impact on parent carers has been significant. We've stepped up our use of direct payments. We've allowed for flexibilities around how people use their direct payments outside of the normal care plan. And again, that's been a huge source of support for many families.
Thank you very much, Jo. I'm coming now to Nigel.
Thank you, David. Right, three questions. Lynn asked about fostering, and I'd read reports early on of a national crisis in the foster sector. It sounds from what Matt said that we don't see that here. If you could confirm, that would be appreciated. On the return to schools and I had a question about 3.14 refers to the mental health cell. Wasn't quite clear what that had done or was doing, if we could enlarge on that a little bit. But the key question there is, as people go back to school, will children have a named adult to go to if they have concerns when they get back to school, which was one of the things I think came out of the young people's survey. And lastly, pressure on parents with children with difficulties. What's happening with respite centres?
Thank you. So if I start, if Jo wants to jump in as well. So in terms of the foster carers, we haven't seen placement instabilities. We haven't seen children needing to sort of leave their foster carers during this time, and we've maintained and we continue to deliver our fostering strategy around trying to increase the number of foster carers that we have.
Matt, sorry to stop your flow there, but have you shared your screen with us? Somebody has. Somebody shared screen.
Is that better?
Yes, that's perfect. Thank you.
So yeah, and we're continuing our strategy to recruit foster carers in Hertfordshire, and that's an ongoing piece of work. And then in terms of children having a named person they can talk to in school, yes, all children that are on a child protection or child need plan would have someone identified within the school that they can talk to, and obviously they'd also have allocated social worker. So that's something that we recognise as being really important for children, having a trusted adult they can talk to, when they're back in the school setting is really important. Jo, did you want to pick up around the pressure on parents with children with disabilities?
Yeah, absolutely. Just a couple of points. So first of all, you referenced the mental health cell. I'm aware that the mental health cell have done quite a lot of really important work over the past few months, one of which is put in place a helpline staffed by CAMHS workers, and I've seen that's been publicised out to schools, but also through schools into parent networks as well, and making sure that where needed, people had direct access to therapies online and in a safe way. In terms of respite, our respite care has been ongoing. In the immediate crisis period, we opened up some sort of emergency respite if it were needed. There wasn't a significant uptake of that. You'll understand that many carers were concerned about using respite because of the potential safety impact for their child or young person. So actually we saw much more of an uptake of direct payment so that people could use short breaks in a more flexible way. But we have kept our respite up and running for children with SEND. It's in place. And yesterday I had an update on sort of summer schemes for children with SEND, because we know that many parents and carers of children with special educational needs who might have kept their child at home over the past few months really do need a break. And we've got, I think it's over 400 sort of places within our summer schemes are open for children with SEND moving forward. That's less than normal, but it's still a pretty good number given the current context. So we are thinking about that short break offer. We are in contact with our families. Those families that we're most concerned about, we're in contact with, you know, on a weekly basis, and social workers are outreaching to them and indeed beginning to do face-to-face work with them now moving forward.
Thank you very much, Joe. Matt, that's excellent. Thank you. I am conscious that I've got Dee and Ron, but I'm going to stop the questioning now on this. Dee, Ron, would you capture your questions, please? Feed them in later. Matt, Joe, Matt, thank you so much. Really appreciate it, taking time out to come and work with us on this. Thank you very much. You're more than welcome. If you want to continue to see what we do, please do. But otherwise, thank you. You're more than welcome.
Thank you very much.
Thank you very much.
Members, I'm going to go. I don't want to put anybody on the spot here, but I'm going to go slightly off piste because I am conscious mental health came up there several times, and we do actually have representatives from the Hearts Partnership Foundation Trust. And without wishing to put them on the spot, if they wanted to take a few minutes to talk to us, just give us an indication of what they've been doing around children's mental health, I think this would be the appropriate time to do it. No, silence. Okay, right. In that case, thank you for that. As I say, those of you who haven't been able to call this time, please capture your question. Oh, yes, we do. Hang on. Hello. Good morning.
Yes, sorry, we're just delayed in joining. Hi, and my colleague Karen's coming on.
Hello. Good morning. Just a quickie. Sorry, I sprung it on you. If you've got nothing to contribute at this stage, that's fine. But you will have picked up concerns around children's mental health there. I just wondered if that's something you would be prepared to talk about for a couple of minutes.
Yeah, in terms of the specifics of where we're at in terms of restoring services, I think.
Yes, I think so. That's where we need to understand. Yeah.
Yeah. So I think broadly we're seeing referrals pretty much up to the levels that we would have expected pre-COVID, but an increase in actual activity that goes alongside that, and some of that is in terms of the proportion of contacts that we have, which are now virtual rather than face-to-face, has significantly increased. So they've gone from about 20% previously to about 80% of all contacts now. And what that has enabled us to do is increase the number of contacts with individuals. So I think in terms of where we're at on activity, we're pretty much up to where we were pre-COVID. But we're also starting to see increasing referrals above that. So we would expect to see probably something like an increase around 10% in demand as we move forward. And I think it was alluded to earlier, we're also expecting to see a significant increase around September, subject to schools returning. And that would be what we would see historically during a year anyway, when we get those patterns. So we're looking at the ways in which to address that as we go forwards. I don't know if Karen wants to add a little bit more.
So I guess the other thing that we're seeing, which has played through, and I think Joe talked around, and Matt, which is around, we're definitely seeing some more acute presentations, more complex cases presenting through into CAMHS services already. Whether or not that is directly related to COVID or not, I think we're yet to understand fully, but we're definitely seeing that present through. So as an example, our inpatient unit, for the first time that we can all remember, has now got all of our young people are now formally sectioned, whereas we would, and that just gives you the sense of level of unwellness that these young people are coming into our units on with. Whereas previously we would have had some young people who we would have informally admitted, which they wouldn't have been formally sectioned. So, and we're definitely seeing, we're starting to see, as Keith has said, referral levels are up already, and that's before schools go back. So that would indicate as well we're going to see some increased demand coming into services at quite a level. And nationally, what they seem to be talking about is somewhere between a 10 and a 20% increase in referrals that we can anticipate across all of mental health services, but CAMHS within that as well, children and young people within that as well.
Thank you very much. That's insightful, helpful, and I'm sure it'll be useful going forward. Thank you very much, Keith and Karen. Okay, I go back to the agenda now, and waiting in the wings is Ian with his team. Ian, are you there?
I am. Thank you,
morning.
Chair.
Good morning. Oh, over to you. How are you going to work this? Because I gather there's several of you.
I think it's just me.
Just you. Oh, okay,
I think
fine.
so.
Well,
yeah.
We are duly honoured. Thank you so much. Appreciate it. Off you go.
Thanks, David. So in terms of impact on adult care services, people wouldn't be surprised to learn that contacts and assessments during the early weeks of the pandemic really reduced. So we were 40% down on contacts with the department and on assessments, 40% down on safeguarding. That's recovered to an extent over the months of May and June. We're not quite back to normal numbers yet, but though all those activity areas were down. At the same time, though, the teams were very busy, red, amber, green, running through all of their lists to make sure the most vulnerable people have been identified in case staffing situations got bad, and we did end up in a situation where we would need to ration care in some way. I'm pleased to say we never got to that stage and we never had to use that work, but it was all there in the wings. Our waiting lists are also at a historic low, so there's virtually no waiting list for adult care services at the moment either. Other impacts, so our commissioning activity has been paused. So the home care contracts that we were going to let in April will now be let in October. Our consultation and implementation of different short break services that came to panel has been delayed, and our day opportunity strategy was put on pause. All of our commissioners were completely focused on phoning care providers, mostly daily, to get updates from them and to make sure they were operating safely. In terms of impact on care services, I say we never had to invoke the legislative requirements in the coronavirus legislation, which said that we could have taken actions to not assess people as fully as we usually do, and change people's care packages temporarily because of staffing shortages. We never got to that stage. We've had a high number of care home deaths, 522, although there is a table now of all councils, all 151 councils with social services responsibilities, and the number of deaths in care homes per care home bed in the area, and Hertfordshire is 76th on the list of 151, so that's right in the middle, but still a very high and regrettable number of deaths. In terms of care homes overall, so you wouldn't be surprised to learn that people, self-funding people, have not been placing themselves in care homes during the COVID period. So the months of March, April, May and June, we've seen record low numbers of completely self-funding people placing themselves in care homes. For the council's part, we ordinarily would place around 80 people a month in care homes, some from hospital, some from the community. That's been running at around about half of that level. And with the high number of deaths, of course, the implication is that occupancy in care homes is much lower than it usually is, and so we're having to monitor the financial sustainability of care homes in Hertfordshire to make sure that they don't tip over in any way and cause a problem for the people who remain living in them. In terms of home care, again, an unusual situation. What we found in the crisis was family said, actually, I don't want my home care for this period. I'll come back to it at the end. And their families, who were often furloughed or weren't working, were able to take care of their loved ones. And so demand dropped by about 20% during the peak of the pandemic. That 20% coincided with around a 20% staff sickness rate, and the two cancelled each other out. And so our home care agencies were able to continue, and we're even able to offer enhanced services, for example, special COVID home care rounds, where people could leave hospital with a test but only be seen by specific fully suited home care workers to make sure we could get them home from hospital as soon as possible. Most of our day services closed during the pandemic, not all though, and I'm pleased not all, because other councils took the view that day services are not an essential service. We didn't take that view, so we kept 7 of our 20 day services operating for families, and particularly for family carers who have got their sons and daughters living at home with them, and day services is absolutely essential for them. And we're finding now that people are coming back to day services as their confidence increases, and it's much more easy not to have a reopening date. They can just come back and we can work with them and expand the service as people return. Similarly with lunch clubs and with our dial-a-ride service, both of those things were closed down, and they'll be reopening over the next couple of weeks. The voluntary sector, as has been mentioned before, have been magnificent throughout all of this, have helped us with Operation Sustain, which is helping people get their online shopping, prescriptions, dog walking, anything people require, and Operation Shield, where we've been delivering food and using volunteers for that operation. And we're now closing down Operation Shield, the food parcels, and passing that to Operation Sustain, so that people can start getting their shopping delivered from the usual supermarket and paying for that themselves. Just finally, it's not all been bad. So the use of technology has really increased, both for staff members in ACS, for our care providers, and for people. And so we need to continue to use it to some degree afterwards. It's been a real eye-opener. People are using technology who never thought they would in the past. And Age UK in Hertfordshire are running a fundraising project to make sure that people who couldn't actually afford the kit can get access to it on a loan scheme, which is great. Our NHS partnerships have been great, and I've got to pay tribute to the CCGs, the acute and the community trusts for working with us so closely, both in terms of policy, but also on outbreaks and on recovery and activity planning, to make sure we had services in place and no part of the system was overwhelmed. That's been terrific. 2 final things to mention. The Hertfordshire Safeguarding Adults Board has commissioned a report in a very small number of weeks to be delivered on what learning there is from a number of care home deaths in Hertfordshire, with a view to preparing us for any second peak that arrives. And so the terms of reference of that report have been agreed, and that's moving forward over the next 2 or 3 weeks. And I'm sure that report will be made available on the Hertfordshire Safeguarding Adult Board website. It's a partnership of the council, the NHS and the police. And just finally, to reflect on some of the things that other people have said, all of my social work teams need to be alive to the fact that the second stage of this might actually be worse than the first, in that some of the problems that people are experiencing won't be as visible as in the first part of the pandemic. So people's physical health has declined. Jim mentioned that. We know that. People's mental health has declined as well, and that's people in care homes and people in the community. People will lose their jobs, people's families will be affected, and so we need to be alive to all those family relationship and caring issues when we get back to full STEAM, assessing people, visiting folks in their own homes, and helping care services get back from preservation of life to quality of life. And that's the journey that we're on now, and we need to be supportive of our care providers to get there. Happy to take any questions, Chair.
Ian, excellent, concise and informative as ever. I'm going to go first in the first instance to Fiona.
Thank you, Chairman. What has been done to ensure that bank and agency care home staff only work in one home to prevent the asymptomatic transmission of COVID-19 into multiple homes?
Thanks, Fiona. Yeah, that was the asymptomatic nature of COVID-19 really became known to us very widely and very early in early May, and the government advised us to take a number of policy decisions to prevent agency staff working from more than one home. And the government provided an infection control fund, 600 million nationally, 13.3 million to Hertfordshire, to pay for the additional costs of only having staff located at one base, but potentially having to pay them for more because they're usually based in more than one care home. So that we've done. We wrote to every recruitment and staff agency, bank agency in Hertfordshire to say that was our intention. We needed their cooperation with that. And we wrote to every care home advising them to take action to make sure that staff members only worked in one place, and if necessary, to pay them extra to ensure they didn't, unknown to them, work in more than one place, and use the infection control fund that was passported through to them for that very reason. So that's what we did, Fiona.
Thank you, Ian.
Thank you, Ian. Yes, excellent. Thank you. Ron, I'm going to call Ron and then Alison and then Nigel.
Thank you, Chair. I'll be very quick. First of all, Ian, the question of volunteers. I note in the statistics on page 12 that 55% of those we had out of the 10,000 were not deployed. So that's one. The other question is following on from Fiona's thing. So if the asymptomatic problem became known in early May, is that correct then? Therefore, the asymptomatic was not aware when the discharge from hospitals occurred. And then thirdly, the lack of carers assessments. I think a lot of carers are getting older, and I think we need to be extremely careful because we rely on carers to actually take quite a lot of the slack caused by just general people living longer, and it would be interesting to know when they will be returned to normal.
Yeah. I'm sorry, Ron. I didn't catch the middle question about asymptomatic and discharge. I'm not sure if everybody else.
Well, there was a sudden discharge of people from hospitals at the early stages of the pandemic, and into care homes. Quite a lot of them without testing, but the guidance from government about agency staff only became known in early May. So I just wanted to know that at the time of the hospital discharges, there wasn't much information to go on, was there?
No, that's right. So if I answer those in order, some volunteers, you're right, 55% were used. Two things with that. We believe that a lot of those volunteers had also volunteered for the NHS and their scheme. So it may be the percentage overall was a little bit higher. I think you might have to go on mute, Ron, because it's I'm getting quite a lot of feedback. Sorry about that. But there are a number that have still not been used. What we've done, we've kept writing to them because what we believe might happen is that when people do start returning to work from off furlough or whatever, we might need to replace the volunteers who have been working with people with a new batch of people who aren't furloughed, who are perhaps retired or have got different times. So we may need the other 45% should some of the 55% return to work. So we're keeping in touch with all of them. On the asymptomatic, yeah, I think that's right. And so what I'm saying is hopefully consistent. The asymptomatic nature wasn't really widely known to the care sector. It wasn't involved. It wasn't included in our policies. We didn't have a sudden discharge of people. In fact, we actually had a lower number of discharges, about 180 between middle of April, middle of May. That was far lower than we normally would discharge. And people who were symptomatic were tested. People who were asymptomatic were not tested. That was the government's policy at the time, and it'll come to pass whether that was the right policy or not, but I'm certain it was followed. What I'm pleased to say in Hertfordshire, we did negotiate with NHS partners, and some of them are on the line, to say where we were unsure or there was any risk at all, could we use NHS beds until people got a negative test? So all that was part of the mix in Hertfordshire, and the Adult Safeguarding Board will pick that up through the care home deaths review. And I did see Nigel's question. I'll make sure the committee gets a copy of the terms of reference of that review. In terms of care assessments, what we've actually done during the COVID period when contacts, assessments and reviews were down is we've tried to focus on carers' contingency plans. So every carer who looks after someone at home is meant to have one of those in case something happens to them for a temporary period of time. So we've tried to look at those and update those to make sure we're ready for any second peak. But I agree, we are expecting an increase in the number of carers assessments demanded, and the teams are ready to deal with that.
Thank you, Ian, and could you extend my thanks to all the staff in the care for all their efforts over the period. Thank you.
Thanks, Ron.
Thank you, gentlemen. Alison has kindly pointed out that her question has now been answered in the submission thus far, so I'm going now to Nigel.
Thank you, David. Hi, Ian. Yeah, thanks for committing to provide the terms of reference. That's much appreciated. Questions. I was actually talking to someone who works for carers in Herts earlier in the week, and I mean, their key concerns were, I mean, I know you said we kept some of the day centres open, but there does seem to have been quite a big knock-on effect from the closure of the others. Yeah. I don't know if you can tell us what the timetable is for reopening now. And obviously there's a big impact into the voluntary sector as well of that. I know I've supported a couple with my locality budget funds, but if you could comment a bit more on the need to provide additional support to the voluntary sector. Yeah, I know you spoke about that at the HWB the other month. And what was the other thing? Sorry, I've lost my train of thought, not for the first time.
Shall I answer the first two questions?
Just answer those, yes, thanks.
That's okay. So on day centres, rather than rushing to close them all, actually people voted with their feet. So attendance at our day centres when they were all open was down 80%. So people were choosing not to come. So what we did was we matched capacity to that 80%, close them down to 7 units where we could socially distance and run a COVID safe service. And then as people have come back, and they're not trickling back, they're coming back in dozens now, then we're opening buildings according to where that need's arising. So hopefully, if people call us and say they want to come back to day services, we'll find them somewhere to go. It might not be their regular day centre and their regular transport round, but we'll make something available to them to the needs that are explained in their care plan. On the vol sector, so we've continued to pay the voluntary sector contracts that the council's got to the same level all the way through the pandemic. And that's because we wanted the vol sector to be able to pay their staff. So we haven't said, oh, your lunch club's closed down, therefore we're not going to pay for it, because we knew they'd be incurring costs. And some vol sector providers have come back to us say, don't worry, we're going to furlough these staff, therefore we only need this amount of money. And that's left us with a small pot that we can now use to boost the funds of the ones that are really struggling. And so Christy Thacker's team is taking forward that work within the budget that she's got.
Okay, thanks very much. The other question I meant to ask, so and I'd lost my train of thought, was there's a lot of stuff in your report which is really good about the what help is available to charities.
Yes.
I suppose my concern reading that was, well, are the charities geared up to actually access all the funding that's available?
Yeah, that's another good point. So again, Christie's team and teamed up with the Hertfordshire Community Foundation, they've paired together to be proactively contacting charities to make sure they know about all the options that are in that paper. And actually, HCF have been able to persuade some of their philanthropists to change the direction of some of their grant giving to favour the agencies that we need to boost and to keep going.
Great, thank you.
Thanks, Nigel.
Ian, thank you so much. I'm not seeing any further questions coming forward. So at this stage, I'll thank you for your time this morning. Always a pleasure. You will be missed. And what I'm going to do now is at 11:05, I'm going to suggest we adjourn for a comfort break and return at 11:35 prompt, if you wouldn't mind. In the meantime, would you please turn off your microphones, turn off your cameras, but stay in the meeting, please. That's most important. We don't want to lose you. So with effect now, if you'd be so kind, take the opportunity to spend 10 minutes looking at something other than the screen, and we'll see you back in at 11:35. Thank you very much. Well, good morning again. Hopefully I'm able to welcome everybody back as we reconvene this meeting of the combined overview, scrutiny and health committees. As we go into this next session, we will be hearing from Scott Cruddington around resources, and then we will have a session with our colleagues from the NHS, Jane Halpin, David Evans, and Keith Loveman and Karen, who we've already seen from HPFT. But as we start into this second stint of the morning, I'm going to ask scrutiny officers to just give us a quick summing up of where we have got to with those first three sessions, which I thought were very useful, quite excellent. While I've got your attention, could I just ask, looking at the chat section, a lot of questions are appearing in there, and that's absolutely fantastic and exactly the way it should be. I'm concerned that we're getting answers there as well. It's just making it a bit difficult to keep control of. I think that's an excellent way of capturing your questions now, but if officers don't respond straight away, I'm sure we can build that into the process later. So officers, if you just hold off replying, capture those questions, they're very valuable, but I need to keep, especially as we go into these two sessions, I need to keep the chat the chat column fairly free. Thank you. Natalie, over to you.
Just a quick query, David. I've had questions from the officers who've presented so far, that once this summary has been made and their sections are completed, are they able to leave the meeting to carry on with other duties?
Oh, I would hope so. Sorry, I did say that, I think, in the first instance, but not subsequently. Yes, of course, absolutely. Their duties take priority now. Okay. But thank you very much for their input. Yeah. Thanks.
I'm going to just lead on public health, and then Fiona is going to pick up on adult care services and children's services. So in terms of public health, I think what members got alongside the information that had been provided in the pack and through separate emails was reassurance about the outbreak planning that's taking place for any subsequent spikes that may occur during the autumn and spring, and also reassurance around the planning that's been taking place in schools to date and what will continue into the autumn to make sure that schools are safe educational environments for our children, including those with SEND. You also heard from Jim that the department is attempting to do two quite difficult juggling acts. One is to continue to provide services to that are in response to COVID, alongside working around the recovery work to resume services that have maybe been stood down or not been as vigorously working as would be previously the case. You heard from Jim that for him there remains a concern around the impact of a second peak, that Hertfordshire residents have behaved with exemplary fortitude up to this point, but actually it's maintaining that over a longer period of time, and also planning for the second peak alongside the usual winter pressures of flu, etc. And so that could be a compounded problem. You also heard from Jim about not only how public health but other services are looking to deal with the multiple impacts of COVID on our communities. So that is direct and indirect grieving that people may have, the impact of mental health for people who have not been in receipt of services or they've got emergent mental health problems during COVID, that there has been physical health deterioration which has to be addressed to prevent those people becoming more isolated, and the inequalities which go across BME, SEND, and the deprived communities that we have in Hertfordshire. So inequalities mask a huge quantity of issues that scrutiny might want to give some mind to in the future. And at that point, I was then going to pass over to Fiona to do the other two services.
Yes, please, Fiona. Near in time.
Yeah, okay. So with children's services, I think probably the key theme coming through a lot of the discussion was the well-being of children and young people, that is something that we've already kind of got on our work programme, and we're planning a seminar, a webinar it's going to be now, and we've just set a date for that, the 19th of August, but we'll send the rest of the full details out on Monday, which all councillors will be invited to, and that webinar will be it will have representatives from NHS as well as HCC, so I think that will be quite helpful in kind of working out if there are areas around that you want to prioritise. And the other key themes seem to be partnership working, which is clearly key to so much of what has worked well. And there's a lot of learning, good learning around that. And I think across all services, but it certainly came through in children's services. And I think one of the other key things, which might be something that Scrutiny wants to look at, is the support that might be needed in future for children and young people, especially those leaving college and education, with perhaps because of the economic impact of COVID, fewer opportunities to get into apprenticeships, work and internships and those sort of things. In that discussion, it was really encouraging to hear that officers were already working on that and looking at that, working with the LEP on that to see what can be done in Hertfordshire, and I think that could be a useful area for scrutiny that members seem to be interested in, and one of the other themes, and this again came through I think in public health, children's services and adult care services, and that is the impact on carers. So for parent carers in children's services, the impact of the possibility of a future lockdown after or after the sort of exhaustion and that they will already be feeling at this time after children not being at school, things like that. That seemed like a key point, and support for parent carers. Really encouraging was hearing about the work that's being done, the helpline for parent carers that they can get in touch with, for children with SEND, they can get in touch with directly, and hearing the example of individualised responses that were really practical, which you could from the example we heard, you could see the difference that would make to a family, and it was a simple solution, but it needed to be individualised for it to be able to provide something like that, and that was an excellent example. But I think that what came across, maybe not so much in discussion, but I know certainly in a couple of comments on the chat, were that members are keen to know what about the families that don't get in touch with this helpline. Do all families know about it? It can be difficult for families to acknowledge that they need to get some support. So I think there's a lot about support for those who are, and this was also children's services and ACS, about those who are identified by the council or those who work with them, but that the possibility of needing support, but not but those who aren't already identified, it's how do they access it?
Otherwise, maybe 1:30.
So I think they were the main key points from that one. Thank you. Oh, do you want me to move straight on to ACS?
Yes, please.
Yeah. Okay. So for ACS, the key, I think one of the key themes coming through was about the pressure on carers, and which we've already talked about, and the expected increase in carer assessments, and it was really positive to hear about, again, the partnership working with the voluntary sector, really reassuring to hear that HCC's approach towards voluntary sector organisations in continuing to fund them to ensure that staff could be retained, even if those services weren't being provided for a time, and that some of the services that were being considered as not always being considered by all councils as essential were being in Hertfordshire, and I think the hearing that HCC were proactively contacting charities and voluntary sector organisations about available funding was really positive. Seemed like an excellent example. There's a lot of learning there around partnership working, and also just to note that the review of deaths in care homes, the terms of reference of that are going to be circulated to the committee, and then once the report is published, the scrutiny committees will be distributed to scrutiny committees. There was one more point on children's services that I forgot to mention, which was the some really positive learning about foster carers, and the fact that the picture in Hertfordshire about foster carers during the pandemic was so positive compared to the national picture. So, you know, looking at the learning there would also be a key thing to do. And that's all from me. Thank you.
Thank you very much for the both of you, Natalie and Fiona, for your summings up. That's very helpful. Takes us sets the scene nicely to take us into the next session, which is on resources. And I'm going to invite Scott to join us for this. Good morning.
Hello there, Chair.
We can compare headsets.
Yes, exactly. Yeah, I'm sure your one is much better, but
no, I've only got one earphone because I'm deaf in both ears. Good morning to you.
Thank you. Thank you very much, Chair, and hello committee. And I just wanted to, I've been trying to work out how I best sort of open this presentation after following children's services, adult services and public health, because it's difficult to sometimes sort of demonstrate what's resources done to support the COVID effort when you're comparing yourselves to the frontline activity and work that my colleagues have so clearly articulated this morning. So let me just try and just take you through some of the key headlines that the way that the accountants, the lawyers, the IT specialists, the librarians, property staff, HR staff have all really sort of put down their normal work in some cases and sort of now sort of flexed in a way that is trying to just support the whole organisation wide effort. So the first area was a very early decision to create a redeployment hub, and with so many staff that were becoming displaced because just we couldn't offer the services in the same ways that we were previously, or we had to just physically sort of shut services, that we created a redeployment hub, which is making a way of making sure that staff that had skills that could be rediverted to other parts of the wider COVID effort. And at its peak, nearly 1,000 members of our staff were redeployed to other activities that was no way associated to their normal day-to-day job. So again, the update report provides some sort of detail of that. And going forwards, I would say that we're going to need to find a way of making sure that that redeployment hub is going to continue for the long term, because as we exit out of probably the sort of the emergency phase of the pandemic, the long-term impacts on our community has already been described. Is going to need a way that we're going to need to find a way that we adapt our services to be able to meet these new challenges. So that hub is going to be important to be able to continue to provide those staff and resources and skills for the long term. Then we touch on about the technology rollout, and I'd like to say it was absolutely expert planning on behalf of the Director of Resources to ensure that the technology was all in place in time for this pandemic, but it was just pure luck that our IT team were ready to roll out Microsoft Teams probably a few weeks before lockdown. I would say that we probably accelerated its adoption, and where normally we do lots of tests, pilots, and then we learn from that, then we adapt, and then we roll out a little bit further. We decided to launch it on the organisation all in one go, and we adapted through the feedback and learning that came back. And I've got to say, from the feedback that we've had, as people started to become more familiar with the technology, it has meant that we have everyone has begun to embrace it and find new ways of working. So that has been a great success. As far as making sure that our members were able to adapt and respond to particularly sort of very specific local issues and needs that were coming about and being identified from COVID, we opened up our locality budget scheme as quickly as we could, and that was opened up on the 20th of March to allow members to access their funding to direct towards sort of COVID initiatives and support that particularly some of our voluntary organisations and community groups needed support at this sort of difficult time. There was an operation that my team was leading on, which was called Operation Hypnos, and that was quite a sort of difficult subject, but in relation to mortuary capacity across the county, as our strategic coordinating group was identifying it as a particular risk, that if projections had gone in and the death rate had followed a particular path, which we're glad it didn't, but if it had, we would have exhausted our mortuary capacity in Hertfordshire very quickly. So through that work, we were able to increase our capacity from 256 mortuary capacity storage up to 1,207 within a few weeks, and that was a great collaborative effort across the coroner service, registration service, police, funeral profession, burial authorities, military, environmental health, faith communities. It was a real true partnership effort. Then a number of my staff and a particular sort of name check to Taryn Pearson Rose from within my team was moved to support both the Operation Shield and support effort. As a result of that, that was not only for those people shielding, but also those that have been identified as being vulnerable and needed more support, where maybe the family network or community network wasn't strong enough to provide that support for them. So within almost a couple of weeks, we had spun up a food distribution service to provide much needed provisions to those that needed it, that could make their own arrangements, but also the creation of a volunteer network of over 10,000 volunteers across Hertfordshire that provided a range of support for those in need. Our communications team needed to undertake a lot of almost like reassurance work for our public in terms of public reassurance campaigns. Needed to make sure that we were proactive as we started to hear sometimes those sort of rumours or sometimes misinformation or misunderstood information, that we needed to correct that as quickly as we could to ensure that people were not being misled through the various different channels that exist these days. And now they're extremely key to the next phase of the recovery phase. Our legal democratic services team have continued to need to make sure that the democratic process continued, and exactly what today is all about, that we're able to continue to hold officers to account, to scrutinise the way that we're undertaking our work and the way that we're spending our money, and through the use of virtual meetings, that has now been possible through all of their hard work to be able to do that. Our trading entities, we've got a range of trading entities that exist in Hertfordshire, and obviously they've seen significant impacts on the services that they provide, such as Hearts Catering, Hearts for Learning, and that we've been very close support to them to make sure that while they've been able to adapt their models for the time being, and possibly for the long term as well. And then sort of just covered the last two areas in relation to probably our council finances. The report goes into some detail around the way that the funding has been made available by government, and that's now totaled just shy of £48 million of grants that have been allocated to the council in terms of direct support for COVID. There are a range of other specific grants that have been made available for payment in relation to support of PPE provisions to not only ourselves but also our partners in care settings, but that 47 million has been a real sort of significant boost to our finances in the short term, but we are forecasting that the total cost of COVID to us could be now reaching upwards of 75 million if certain risks do materialise over the rest of this year. So there is a gap, and there is a need for us now to look at our medium-term financial plan to ensure that we can build that and address that gap over the medium term. But it's highly likely there will need to be further injections of funding, which the government, to their credit, has been giving more indications there's going to be further funding injections, and we're looking to hear more news about one actually today. Probably the most significant concern that I have in relation to our finances will be around how council tax income stands up over the coming months. There's some forecast that we could be 5% down on normal collection rates across Hertfordshire, and that could be could create quite a significant hole in our funding, upward of £30 million on top of those concerns that I've already outlined. So we're in constant dialogue with the CFOs in all the district councils to keep updated on how their council tax collection rates are going. And then finally, it's probably important that I should mention around what we're doing in relation to supporting our staff. Again, through our recovery planning, that we are considering both the mental health and almost the post-traumatic stress disorders that may well follow as a result of people now coming out of the lockdown situations and scenarios we find ourselves in, but also then what are we going to do to be able to return people back to the workplace in an appropriate way, but also address maybe a range of different concerns and issues they may be facing in their personal life as a result of the situation they've found themselves in through lockdown. So again, there's a range of support measures that we're putting in place for staff over the long term. But we must also acknowledge that, there's a level of a sort of exhaustion. A number of our staff that have been finding that they've not yet had a break. We are very much sending out strong signals and messages that although people may not be able to take holidays in the normal way this year, that we would be encouraging people to take the leave and take a break from their activities over the course of the summer, to be able to give them a bit of a break, and then also gear up for the recovery phase that will be probably going on for the rest of this calendar year. So I'll leave it there, Chair. There's a lot of issues to cover, but I hope I've been able to try to demonstrate that resources played their part in the COVID response. Thank you.
Well, Scott, yes, certainly you have, and it will come as a revelation to many of us just how broadly your directorship has been involved and contributed to this. In the first instance, I'm going to go over to Sandy. He has a question, I think, about resilience.
Yeah, Scott, thank you for that. Actually, your last comments about the resilience and the importance of staff actually being looked after and looking after themselves, I 100% agree with that. The question I wanted to ask was, there is the Resilience Forum, and I think that's a very interesting body. And clearly, at the moment, it is 1000% concentrating on the immediate challenge. But we also know that there are longer term challenges that we can't lose sight of. And I think particularly about environmental change and the risk that may come if we get into a world of uncontrolled feedback loops because stuff has happened elsewhere, and flooding and all that kind of thing. And I just wanted some reassurance that whatever we do in tackling COVID, first of all, doesn't in any way damage longer term planning like that, but secondly, that we are keeping those longer term issues in mind and not just putting them in the don't worry about that for now box, because I think we have to be constantly worrying about that.
Okay. Thank you, Councillor. Let me give you absolute assurance that those longer term strategic issues that we face as a county remain centre to our considerations, and just on the particular example that you give in relation to environmental sustainability, just over the last couple of weeks, the draft Hertfordshire Environmental Sustainability Strategy with its I think it's something in the region of a 100-page action plan, and this is obviously over a significant period of time, but where the County Council now needs to direct its recovery to ensure that we maintain our sort of ambitions off of the emergency climate change declaration we made at Council a few months ago. And so therefore there is a very strong ambition about that this should be a green recovery, and we should be making sure that the way that we now design our future way of working, and we've got a programme that's now established called Shaping Our Future, and rather than a vision of where we used to, with significant numbers of people travelling into the organisation, undertaking their duties by necessarily getting into the car or whatever to perform their duties, the use of technology now, the use of changing the way that we work through multiple workplaces rather than just a single workplace, to avoid that need for constant sort of travel, and therefore impacts on the environment is front and centre of our future plan. So it's only one example I can give you there, but that is really important, but that is very much in the forefront of our thinking. Thank you.
Thank you, Sandy. Thank you, Scott. I'm going to take a question from Fiona, please.
Thank you, Chairman. Scott, you mentioned staff and annual leave. Is there a reluctance by staff to take annual leave, feeling that it'll be wasted if they can't go away or can't go away to a place of their choice? They want to save it up for later in the year when they can.
Thank you, Councillor. Yes, it is, and what we're concerned about is both from obviously from a staff wellbeing perspective, that we are now really increasing our sort of messaging around encouraging staff to take place, but then from running a business perspective, we're also concerned that if everyone does save up their leave, and let's just say restrictions do reduce significantly over the winter period, that's just conjecture, but if it did, then there's a danger that we end up with almost like an excessive amount of capacity lost from the organisation at one point in the year, which is not normal, other than maybe some of the summer periods where we manage through that. So yes, your conclusions are correct, and there is that reluctance that we're picking up in talking with staff, but we're doing all our best now to try to increase those messages to encourage it more.
Thank you.
Thank you, Fiona. I'm going to go to Roma now, please. Roma.
Thank you, Chair. I would just comment on the last point that people have had to change the way they work hugely, and being in front of a screen all the time or online is actually very taxing and demanding. And certainly in my workplace, I'm encouraging any of my team to take regular breaks each week because it's too much, actually. It seemed easy, we'll all work from home and we'll all be on the computer, but actually non-stop Zoom or Teams is exhausting. However, my question is slightly different. I was interested to see in the report, Scott, that your directorate played a key role actually in the mobilisation of the 10,000 or so volunteers that came forward to support in their communities. I mean, they're going to be an enormous resource for the future. I appreciate some may have been people who are furloughed, and that's maybe why they had the time, but nonetheless, we really do need that resource. How key will your directorate be in trying to sustain that enthusiasm and to keep those people in a volunteering mode?
Yeah. Thank you, Councillor, for your question. Yeah, our role within the department will continue to support, but I would probably give you some confidence that Ian McBeef's area has already developed a set of proposals and a paper that's come forward to our strategic management board on how we now sort of capture the sort of this opportunity and this volunteering effort that has come forward. So, you know, we've almost sort of described it as the equivalent of our Olympic legacy, about how we now make sure that that this volunteer effort is now directed and encouraged to continue to play a part in public services across the county. So we're looking to establish a number of functions and some resources that will now be dedicated to try to now encourage that volunteering effort to continue. So rather than us almost like just backing off as these initial responses such as Sustain and Shield wind themselves down in due course, that we will have some resources and people that will now be focusing on how we then move that volunteering effort and direct it in the future. So yeah, it's very much thought about how we make the benefit for the long term.
Thank you for that. That's a good contribution. I'm going to go now to Seamus.
Thank you. Just on muting then. The integrated plan process, it's very complicated, and it's a very good tool that you run to ensure that budgets are managed properly. Could you give us some clarity to the current position on that, and possibly the year 21-22 as well?
Yeah, okay. Thank you, Councillor. So we've been running a range of models on the likely impact on our budgets over the medium term, but there's so many known unknowns, to coin a phrase, that my ability to be able to provide members with an accurate forecast at the moment is quite limited. And you know, if I tell members that we could range from a potential budget gap next year of 50 million, but it could be as low as 10 million. Depending on a whole range of different factors, such as how council tax collection rate sustains itself over the coming years, what the levels of funding from the government comes through, what the level of income guarantees that the government is now starting to indicate it will provide councils, to what level that will provide. So apologies that, you know, that we're very much from an accounting point of view that it leaves us very uncomfortable to have sort of variations and sort of to this sort of level. But you know, the gaps that we are planning for, and as you would expect, that we need to scenario plan answers for both the worst case and the best case scenarios, could be anywhere between the 50 million down to 10 million.
Thank you very much. I'm just checking. I think it's Roma next. Roma followed by Ron, and then I'm going to close the questioning down on this section. Thank you.
No, I think that was a mistake, Chair. You can let me off.
Oh, no, Roma, you wouldn't have made a mistake, surely. No. Okay, thank you. Ron, over to you.
Thank you, Seamus. But in actual fact, David, but Seamus asked the question I was going to ask about 21-22. So you've got time for somebody else if you want.
Okay, Ron, thank you. No, that's excellent. Thanks, Roma and Ron, for coming up there. No, there are no more questions at this stage. So Scott's got off. Got off quite lightly there. Well done. No, just a last call. Any more for any more? We are on time, so just a last call for any questions. No, there aren't. Scott, thank you very much for your contribution. Very, very interesting. As always, it poses more questions than it answers, but that's the nature of the business we're in. So thank you very much for that. We will now move on to the NHS, and I'm going to allow a little more time here. Perhaps go out to half an hour on this session, because we've got multiple contributors, and obviously we're very keen to learn as much as we possibly can. So a very good morning to you all. Jane, are you going to lead the chase on this?
Yes, I was going to suggest that if I start us off, and I have with me today colleagues including Sian Elton in place of David Evans, because David and I were booked to the same meetings this morning, and Keith Loveman and Karen Taylor from HPFT. So if I try and maybe give an overview, I want to start by saying very clearly that I rejoined Hertfordshire at the start of June, so most of the issues I will cover are in terms of the response to COVID. Colleagues other than myself would be better placed to answer any specific questions, but I've now been in post coming up for 7 weeks, so with that caveat, I'll sort of kick us off. I want to start, as a number of people have touched on in the different presentations, by just recognising the incredible hard work of staff in the NHS, in local government, in community and voluntary sector, in care homes and domiciliary care, across the duration of the response to COVID. That includes people who've been operating on the front line, dealing with patients, but also those people who've willingly been prepared to be redeployed, sometimes very short notice and into quite different work areas, and the adaptations that people have had to go through to virtual working, as we've touched on, but also the working in personal protective equipment, particularly in summer months, which is can be extremely uncomfortable and actually very, very hot. So I think it's just important that we probably start. I think we start with thanking those individuals across all organisations. In terms of health generally, as the report picks up, there've been changes and work done really across the entirety of the health and social care sector. In terms of hospital response, as well as the very immediate impact in terms of switching off of large elements of routine care, the repurposing of facilities to be able to provide care for COVID patients in a very short space of time. The other adaptive impacts and positive impacts in a number of ways have included things like establishment of single point of care, a real rapid progression of discharge to assess in a very fundamentally different way, something that has been very much a desired piece of work over a prolonged period of time, coming through very quickly, and has been touched on in earlier presentations, repurposing of things like community bed stock to be able to use for patients being discharged from hospitals whilst COVID testing was undertaken. In terms of primary and community care, very different sorts of needs for adaptation and response, but no less comprehensive and challenging to achieve. I think it's very noteworthy and often isn't called out positively in presentations that general practice has kept functioning throughout this. It's had to change the model pretty much in the space of a couple of weeks from what people would typically have expected to a very rapid and wholesale embracing of new technologies, including telephone consultation and triage, including video consultation. But actually, in terms of its ability and willingness to support patients both acutely and with long-term conditions, it has been incredibly impactful. And I think, again, tribute needs paying to that flexibility and innovation. Examples, again, of other aspects of change include the establishment of essentially hot-cold working, which is quite a new thing for primary care to enable potential COVID patients and respiratory illness patients to be separated out and seen rapidly, but away from other patients. Other aspects of the development have included very significant support to care homes, not just in terms of supporting care home patients in a different way, again through primary and community services, but also the support to those facilities around their infection control and also around establishing secure supplies of PPE. As we kind of have moved through responding from that very initial phase, I think what we have seen, and again, sort of probably three things I want to then focus on. I think the support we've had from the community and voluntary sector has been absolutely key. Again, other contributors have referenced different aspects of this, but there certainly the feedback I've had from so many primary care colleagues is the renewed respect and recognition for that very local and interconnected web of services that has managed to allow statutory services to continue to function in a very difficult and different environment. Whilst we're seeing at the moment there's an increased focus on testing at all levels, and I think that will continue to change. It's changed a lot over the recent couple of weeks, so I don't particularly want to sort of dwell on the details of that now, but just again to sort of draw out the different strands that are becoming more commonplace. The role of testing of staff, and again staff in all care sectors, not just NHS staff, is becoming increasingly operationalised and systematised, and I think as we begin to better understand the role of asymptomatic spread, that is going to be a key element in future suppression of infection and control of outbreaks as and when they occur, but also the testing for cases which has improved, and the surveillance testing that is taking place in a number of different ways to continue to estimate population levels of spread, and that's something that Jim and I and others continue to discuss and watch very, very closely. And then lastly, I want to finish, as largely what Scott did, by just referencing the need for current and ongoing support for our staff, both in terms of the sorts of issues that have been flagged of overload and burnout and the need for people to take time to recuperate, but also the longer term psychological and mental health impacts on staff. It's been, for some people, weirdly, it's been a strangely positive experience to have a very clear focus and purpose. For other people, this has been very, very distressing, including the loss of colleagues and loved ones. And we don't really yet understand fully the overall impacts that may well place on our staff going forwards. But also we are working with staff now to plan for potential increases in COVID later in the year. And again, there are both practical aspects of that around staff training and deployment, but also as we better understand some of the differential impacts COVID has had on different ethnic groups, for example, on different age ranges, we have to continue to work with all staff so that redeployment it does minimise the risk of infection or serious infection, but also that we do not inadvertently overburden other portions of our staff in a way that increases that psychological and mental distress. So that's a rather quick overview of what has been and continues to be an extremely challenging picture for health response. But I will pause at that point, and I don't know whether colleagues, my health colleagues, want to say more at this point, or whether they are happier to pick up questions as they emerge.
Jane, thank you. Very useful. Can I ask your colleagues? Is Sean there? Sean, does Sean want to say anything? No. Okay. So, do Keith or Karen want to add to what you said to us earlier?
I think
specifically around children. So, if you want to be non-specific.
Yeah, I think if we could, Chair, that we'd appreciate that. If I kick off, and I think between myself and Karen we'll certainly divide the duties. I wouldn't mind opportunity just to say a little bit about during the crisis and running services, and then Karen's going to add some content around restoring services and reshaping them going forwards. We'll try not to repeat what's in our report, which I understand all members have, but it's probably just worth noting some of the key issues that we faced right from the start of the pandemic. So we've seen about 20% of our staff off with COVID-related illnesses at any one time, and particularly during the peak period. And also, of course, just like other organisations, quite a plethora of new guidance that we needed to adapt to. And that's made some significant changes in the way that staff have had to work over the period. But actually, they've taken forward quite a number of innovative practices, particularly technology-related ones. We've also experienced, and staff have experienced very much, both emotional and physical impact of the pandemic, and we've put a lot of support around staff in that respect, and that's still ongoing. I think of note is that only one service that we run was closed during the period, and that was just closed to new referrals, our early memory diagnosis and assessment service. And I'm sure members will be aware that that's actually accessed by generally elderly members of the population, and they're often frail and vulnerable. So it was appropriate for a period of time to close to those new referrals, but those are now open again. I think the key thing for us was that we managed to maintain all of our services as open, although a number of staff were redeployed to sustain core services, particularly those around inpatients, our crisis services, and that was the case across all of our care groups, so children right through to elderly services. Right at the start, we risk stratified and risk assessed all of our service users, not just for their mental health needs, but also for their physical vulnerability to COVID. And that enabled us to ensure that the people most at risk were absolutely supported as much as possible. And just to give a bit of context around that, so we had over 3,000 service users who were effectively categorised as red in terms of their mental health needs, and a similar sort of number around vulnerability for COVID itself. And as part of that process, we've also run a self-assessment, risk assessment for all of our staff, and we've been able to do that for 100% of all of our staff, and that's been very much welcomed by our BAME colleagues, who we recognise have a higher vulnerability to COVID itself. In terms of risk assessment, we've also assessed all of our premises, and we do that on a weekly basis to make sure that actually we continue to maintain safe working for staff. I think the other thing that I would add, and it's in the paper as well, is just that we've set up a number of additional services, and we're going through a process of evaluating those to ensure that those that have been successful, we either adopt or adapt and restore those other services that have run for a period of time at lower capacity. Of note, I think, are those that have helped other partners within the system. So we set up an A&E diversion function, and we will look to keep that going, 24/7 helpline, and that's been for service users, but also for staff across the health economy, and also social care staff from whatever setting that they come from. So that's kind of a brief run through, and I'll invite Karen to just talk a little bit about the restoration of services and how we're moving forwards.
Thank you very much, Keith. Yes, Karen, would you take up from there? We're not hearing you. You're very faint, so I don't know if you're muted or you've got a microphone issue. We can't hear you.
Can you hear me now?
Yes, wonderful.
Great. Keith and I are sat in the same room, so I think you probably heard me through his microphone to begin with, so apologies. So Keith's given a really good overview, and as he said, all of our services are currently open and receiving referrals, and I think what I think I indicated earlier that we're now seeing our demand levels back up to where they were, if not slightly higher in some services compared to the sort of pre-COVID period. What the key area that we're seeing where referrals haven't come up to their normal level is interestingly around our wellbeing services, which is our services that are there for anxiety and depression. So what we call our improving access to psychological therapies. And that's one thing that we're working with public health with now around how do we make the right nudges to our communities, to people living in our population, to actually encourage them now to look after their emotional well-being, their mental health, and actually self-refer themselves in. Because interestingly, what we've seen is, as Jane has said, primary care has been open throughout, and we've now seen primary care referrals coming right up to the levels they were pre-COVID. But we're seeing self-referrals, which is where we see quite a lot of those referrals for anxiety and depression still remaining relatively low. So about 20% down on what we'd normally see coming through our services. So that's a key area of focus for us as we restore. The other areas, obviously, we talked about the impact, the wider impact this is going to be having on the population, on individuals. And so we're again working with Jim's team around modelling future demand. And we anticipate that we're likely to see more presentations of people who have experienced trauma, who perhaps need services like post-traumatic stress disorder services, and those who might need more support with anxiety and depression as we continue to see the economic impacts of what has happened around COVID and being in a recession. And we're also seeing that people are taking longer to come forward. So I mentioned earlier around people presenting perhaps more unwell than they were previously. So what we're trying to do is encourage, actually, don't wait, come forward and access our services. The other areas we restore is, and Roma mentioned it earlier about how we're all using technology differently, and Keith said the shift that we've seen. We're doing a big assessment now over the course of July and August about how can we continue to use this technology, but in an appropriate way for our service users and our carers. So we know for some service users and carers, it's been a really positive impact using technology to access care and support. For others, they've struggled with it, and it perhaps hasn't provided them with the level of support that we needed. So as we restore, we will see ourselves moving back to more face-to-face interventions and support, but we also want to maintain the level of sort of accelerated use of digital technology that we've seen. And then finally, just to say that we did put a level of psychosocial support across the system, and we've seen staff from care homes, from the third sector, from as well as within the health organisations, all access that support, and it's really important that we encourage that across all of our organisations going forward in terms of giving that level of support to staff as we continue to go through this period. We've also got a programme of reshaping our services, which was already underway within HPFT, looking at how we make sure that our mental health services and learning disability services are innovative, providing the best possible care and the best possible outcomes we can achieve. And so we've just restarted that entire programme, and crucial to that is the service user and carer involvement and co-production in the design of that to make sure we get that right. But I'll leave it there because the rest was in the paper, I think, and happy to take any questions. Thank you, Chair.
Thank you very much. Thank you very much, Karen. Very, very fulsome. Thank you. Most helpful. I'm going to come back to Sian now because Sian had technical issues a little while earlier, but she's now back with us. And so I'm going to invite Sian to contribute. Thank you.
Thank you very much, Chair. I just really want to add to the contributions from Jane and Karen and colleagues. So I think, Jane talked very much about the fact that primary care have had to step up and actually consider to maintain a relatively high level of activity throughout COVID. And part of that, their response was obviously the need to design what Jane referred to as hot sites in regards to the management of COVID-19 patients. And indeed, all of our providers in health had to do exactly that. So I think one of the things that were going on in the background at all organisations that hopefully patients won't have necessarily recognised was that we were having to put in place COVID-19 and non-COVID-19 pathways for across all services and that is hugely resource intensive, as I'm sure people will appreciate, given the constraints around workforce, because COVID-19 hasn't been has hit all services, and it's it hasn't differentiated in terms of those people that have been impacted at all. So huge issues in terms of staffing, which again Keith and Karen have also alluded to. And I think the other thing that Jane mentioned that I just wanted to emphasise really was the coming together across the health and social care in terms of the response to care homes. And that was largely in part enabled by people embracing the technology, and I think we managed to see some real innovative practices as a consequence of our response to COVID-19, and ensuring that patients in care homes were having the correct level of kind of clinical oversight and management, because of the fact that we were able to utilise technology very, very swiftly. I think those are the main things that I wanted to say. In terms of activity from an acute perspective, very similar from a mental health picture, activity beginning to return to normal. Referrals are still about 25–30% down. A&E demand is broadly back to where it was pre-COVID-19 for adults, still down for children about 25%. But actually, we've some of the demand, as we know, particularly for A&E, we've struggled in the past to make sure that patients go to the right place first time. So some of the things that we're doing through the recovery phases now are beginning to learn the lessons from the pathways that we've put in place, with a hope that actually some of that activity we can divert through the use of new pathways. Thank you.
No, thank you. That's most helpful. Thank you very much. That's useful. We now go to the question phase, and this is the moment which Chairman dread, because between you've attracted a lot of interest, and we have we've got considerable number of people wishing to ask questions. But I'm going to exercise my prerogative, because we've got a number of people who have been active but haven't been able to get their questions in time. So please bear with me. We'll try and get everybody. I've got 8 at the moment. We'll try and get everybody through. 9 with Roma. I just noticed that one. So I'm going to start with Dee, who's been most patient. Dee, your question, please.
Thank you, Chairman. At the moment, I'm concerned regarding the backlog of outpatients appointments. As you are aware, a number of these were suspended during the COVID outbreak. Now we are in a recovery stage. How long will the NHS take to catch up with the backlog of appointments? Thank you.
If I can, I'll start with trying to address that, and it may be that there are specific contributions from Karen and Sean around specific services. You're right that outpatient appointments for the vast majority of patients have not taken place in the usual way, but pathway by pathway that has been different, and hospital by hospital the processes by which things were switched off and are being switched on are also slightly different. Where there are high risk outpatient pathways, so for example what we would refer to as cancer 2-week waits, those services have been kept running, albeit with restricted capacity as best could be managed. And therefore we have continued to see patients coming through on those pathways. Where there have been additional challenges for those types of pathways has actually been around the next stage rather than the first outpatient appointment, so needing to have specific investigations undertaken. If I pick one example, just sort of to make the point, many patients need to have an endoscopy as part of their investigation pathway, and endoscopy was a service under considerable pressure before COVID, but as it involves the insertion of a camera through the throat, making people cough, the impact of doing this in a COVID secure way has further reduced available endoscopy capacity, because equipment and rooms are needing cleaning in between patients, and therefore the the fast turnover of patients has been severely impacted. So we've got some pathways like that where they're running but under pressure. Other pathways were essentially completely switched off and are now being restarted. So more routine, low risk outpatient appointments, and the, excuse me, not now. Thank you. Sorry. So again, service by service and hospital by hospital, the exact processes by which those are being reactivated vary slightly. Some pathways lend themselves to more virtual appointments and ongoing virtual contact than others. An example of that might well be dermatology or skin, where actually professionals being able to look at a picture of a particular rash or lesion are able to triage very successfully a very high proportion. So those pathways will come back faster. The main ones that are going to be impacted for some considerable period of time are those where investigations like the endoscopy that I've touched on are needed. But the work that is taking place at the moment across the acute hospital sector in particular in Hertfordshire is to identify exactly those backlogs service by service and come up with recovery plans to restore those services as soon as possible. But at the current time, I think it's simply not possible to give you a sort of a numerical answer, Dee, I'm afraid, other than to say that the work is taking place as we speak. Sian, I'm not sure if there's anything additional you would want to add to that.
I think I'll just support what Jane said, really. You know, the constraining factors clearly in terms of being able to return services to normal are workforce, PPE, and capacity in terms of room space. So as Jane said, you know, the activity that can be done during a course of one working day in any particular endoscopy suite or indeed a theatre is significantly reduced as a consequence of COVID. So that, you know, all of that needs to be worked through by service and by pathway in some instances.
Thank you very much. Thanks to the peer review. Right, I've got another 8 members that wish to ask questions. So I've apportioned them thus, and we'll call you forward in this order. Jonathan, Chris, Nigel, Ron, Seamus, Fiona, Margaret, Roma. So, Jonathan, if you'd be so kind, thank you.
Right, thank you very much, Chairman. This is for Miss Halpin, who made reference to GPs and the fact that, you know, they were sort of open during the lockdown. However, I think that wasn't the perception from a lot of people, because if you go to doctor surgeries, there are often posters up saying, you know, if you think you've got COVID, just go away and leave us alone. And I think many people had felt that unless they were really desperate, they shouldn't contact their GP. I'm not saying it was in the mindset of the doctors. I'm not saying they weren't working in other ways through telephone and online and the rest of it. But I think the perception was that we're closed for business. And I'm just wondering if we should be in a similar situation again, and one hopes not, whether their approach, their publicity might be slightly different and slightly more welcoming. Thank you.
Yeah, thank you. I think it's a very fair point, and it is something that we've been working on, particularly with sort of the communication side of the response. I suppose a number of strands to draw out there. I think the immediate messaging did give an impression that there was less service accessibility than actually was in place, and it's taken a little bit of time for that to filter through. But in common with some of the observations that we've heard across this morning, there has also been a sort of a patient-led reduction in demand. So, and if you think back to the very early days and the sort of the national messaging around, you know, stay at home, save the NHS, I think that was very much reinforced at a national as opposed to a local perspective. I think the second thing to sort of draw out is for more routine, regular primary care consultations. So more typically supporting patients with long-term conditions to manage those conditions. That has, for many practices, been something that they have had to do quite a lot of thinking about, is how can you re-engineer that in a different way, particularly when aspects of providing that care involve, for example, regular blood tests, and actually access to those tests has been impacted along with other tests. I think the third bit that, and again, I think Karen highlighted this particularly in relation to mental health services, but it's true equally for primary care and hospital services, is there is a considerable worry from professionals now that the message has kind of stopped patients with symptoms coming forward who should come forward, that the risk threshold has been set at the wrong level, and patients with worrying symptoms that might indicate cancer, might indicate heart problems, and so on, are not presenting at the rate that we would normally expect them to, and that gives us great concern that there is further build-up of advanced illness that may come to light, and that worries us for two reasons. It can be much harder to treat successfully, and therefore patients may actually be increasing their risk of ill health or indeed death by trying to avoid what is currently a low risk of infection and ignoring symptoms that are of concern. So we are very keen that we tailor the messaging going forward, which I think is your point, to give a more as balanced suite of information as possible. But thank you for raising that.
Thank you.
Yeah, it was an excellent question and a very a very pertinent answer. Thank you, Jane. I'm going to go now to Chris.
Very quickly, it's a similar sort of question. Are we convinced that all GP practices pulled their weight during COVID-19? Because I picked up anecdotal evidence of someone ringing the surgery and saying, "Oh, we've got nothing to do here." Well, that's, whilst they don't work for the NHS, it's an NHS resource, and the NHS was under pressure. Were GPs all pulling their weight in the way that was necessary to fight a pandemic?
So I cannot give you chapter and verse on every single individual practice, but what I can say is all practices were open for business as best they could mobilise those different ways of working, and practices have also worked very flexibly in terms of providing staff to what we've called the hot sites in different ways. Obviously, some practices are bigger multi-partner practices than others, so it's not that all have the same amount of resource that they could contribute, but yes, we are confident that there has been a system-wide positive response from primary care in its entirety. The slight, I guess, caveat that I will make, and I think it follows from the previous conversation, is what I can't know is quite how encouraging or discouraging perhaps reception staff have been to initial calls, and that some may have been more defensive or more interrogative in their initial response than others. But I am absolutely confident that all practices have really gone above and beyond to adapt and provide as much services as they could in very challenging circumstances.
One tiny supplementary, which you may not be able to answer because it's questionable as to whether this gets scrutinised at all, and that is dentists. There are a lot of concerns about the unavailability of dental care, including emergency dental care. And I'm now hearing that there are massive charges being levied for PPE. My hairdresser, I do have a hairdresser, I'm that sort of man, charged me £5. I'm hearing 25 and 30 being charged by dentists. Fundamentally, for the patient, it's the same kit.
So again, first caveat is primary dental care services are not commissioned locally; they're commissioned through NHS England. But I think the concern you raise is actually a very valid one and has been the subject of a number of discussions between ourselves and NHS England colleagues. I think on behalf, generally speaking, of dentists, I think there has been considerable concern they have raised professionally with their own organisations about, again, whether the advice that was being given was too draconian in terms of restricting access to all dental care for a prolonged period. And clearly that has been an additional impact on NHS medical services, as patients with dental pain had to present to non-specialist dental services, although again there have been small amounts of emergency dental care made available right the way through this for emergency cases that needed to be treated. In terms though of the PPE issues, and I can't again comment on details of charging practice by practice. Dentists are independent practitioners, and some are fully NHS, some are mixed NHS and private, and some fully private. What I would say is there are some slightly different concerns. If we just take that sort of hairdresser example as a starting point, because of the nature of much of the dental care carried out, it does generate respiratory spread risk in a way that hairdressing doesn't, and therefore the additional cost is in part about lost capacity, as they have to clean rooms and allow rooms to air, meaning that fewer patients can come through, but actually you're still employing the same number of staff. So it's not quite just the PPE in terms of face masks or visors that I think is the issue in dental care. It's also the wider impact of higher levels of infection control and the impact that has on the balance between income and expenditure. Lastly, I would say I think it is something that remains of considerable concern. It's not something that is necessarily talked about a lot in terms of healthcare, but actually the ability to chew and eat and swallow without pain is a very significant part of well-being. And I think what this last 4 months has shown most of us is how quickly dental problems come to the fore when the services are switched off in the way that they have been. And that's something that really does need looking at as we learn how to live with COVID going forwards.
Thank you.
Okay, excellent. Thank you very much. I'm going to call for Nigel now. Nigel, are you there? Yes, good morning.
Thanks, David. Yeah, so first off, I just want to highlight some of the positives that are coming out of this. And section 11 of the NHS report, I think it highlights some of those. The moves towards integration seem to have been speeded up, and that's a very, very good thing. And I'm sure there are other good things that have come out of this in terms of changed working, which to be applauded. I've got two challenges, though. One to the NHS on data. There's a reference in section 2.4 to there being different rates of infection and death between the care home sector and the general population. That's not coming through explicitly to the reports we're seeing as members on our regular updates. Would love that we did get more information on the detail of where we are seeing specific caseloads as we move forwards, and what I'd really like to see, you don't need to respond on this now, Jane, just a comment, is a return to the data we were getting up until May, where we were seeing data on hospital admissions. As we're in this phase now of potential recovery but still severe concern about potential second wave, those early warning signals I think really need to be shared more widely. I know the strategic bodies are seeing them, but I think the wider members also need to be seeing those. So that's just a comment. I've got a particular challenge to HPFT and the comments about the wellbeing service and anxiety and depression. I know from conversations with the wellbeing team here in Welwyn Garden that new referrals were basically being told that there were no new referrals being taken back at the beginning of the COVID crisis. And my understanding is that that is still limited. So I don't think what's in the report or what Keith was reporting is actually correct. And I would like some commentary on that. My understanding is that most people were being offered an online CBT, Silverline, but with no, or Silver Cloud, I think it's called, but with no personal contact to help them navigate through that. And whilst some people will find that straightforward, others will not. So, and maybe the lack of self-referral is a reflection of the fact that people have just got frustrated with the lack of response.
You going or me? Me. Thank you very much, Councillor. Our services have remained open, and certainly we were also signposting over people to things like Silver Cloud in terms of supporting them to receive access to some support more earlier. What we did say was that you might have to wait longer because some of our staff were redeployed to some of the more essential services that Keith talked about. So certainly we weren't running at full capacity during the period, but we were fully open. As we're restoring, we're beginning to move all of our staff back to where they were in their existing teams, and we'll see that capacity go up. But I do want to reiterate that at no time was the service closed. We might have signposted other resources that service users could access in the meantime whilst they waited for their appointment to come through. And the other thing to say is that what we have had to change is we're doing very little face-to-face. It's all IAP services, wellbeing services are now predominantly virtually being provided, and that probably isn't going to change for the foreseeable future. Keith, is there anything you want to add?
Yeah, I think there's probably two bits. I think we mentioned earlier, we're doing an evaluation of all of our virtual consultations just to assure ourselves of the level of efficacy of those. And I think Karen said, for some service users, that will have been a very fruitful way of accessing services, and for others that were different. But we want to see the extent of that to see what level of that we need to continue with. I think the other thing I can say to reassure you is we are actively seeking that demand to come back into our IAPS and wellbeing services. So actively asking GPs, make sure you are referring the people who need to see us back into our services.
That's good to hear, but I when you say we are fully open, if the capacity is reduced, that's not strictly speaking true. So just take that as a comment.
May I just respond to that, Councillor, in as much as our waiting times are below 6 weeks at the moment, and that's what we're commissioned to do. So anybody accessing our services at the moment can get into the services. So I just want to reassure you that that is the case currently, but I hear what you're saying.
Thanks very much. Okay.
Over to you, Ron, and then I'm going to call the last questioner, which will be Seamus, and I'm looking to wrap the questions up now in about 5 minutes time. So if you wouldn't mind. Thank you.
Thank you, Chair. Can I point to paragraph 4.5 on page 61, which talks about multi-agency discharge cells, and then 6.4 paragraph on page 63 refers to care home outbreak cells. Now, multi-agency discharge cells, could we please have a date when they were established? And I just want to confirm that the care home outbreak cells were at the end of March. Was that actually at the end of March or the beginning of April? And are they similar? Are they different? What actually is the difference between them?
If it's okay with you, I'll respond to the questions, those two questions. So the discharge cell, in effect, pre-COVID, we've had an integrated discharge cell across Hertfordshire, sitting in both West Herts and in East North Hertfordshire. So as part of the response to COVID-19, that cell came together more formally as part of the response. Obviously, we were in a command and control structure with a national a level 4 incident at national level, and so that came together that as a cell helped support the response across the local resilience forum. So we've always had, or for many years in Hertfordshire, we've had integrated community teams focusing on discharge. The care home outbreak cell is different, and it is specifically to respond to the management of an outbreak in a care home. And again, that cell was set up at the time that it, as part of the response to COVID-19, to manage and oversee the day-to-day response to outbreaks in care homes, and to ensure that the right infrastructure and support was being put in place into those homes, some of which Jane talked about earlier.
Just confirm then that as far as the multi-agency discharge cell, it actually was already present at the start of COVID, and that just swung into action immediately. And that was what was used to actually discharge the number of patients from hospital into care homes when the government requested it at short notice.
The role of the integrated community teams is to manage complex discharges from hospital, and some of those people will be going back into their own homes. So it's not just management of discharge into care homes.
Okay, thank you.
Thank you very much, Sean. Thanks, Ron. Floor's yours, Seamus. Seamus? Oh. My screen's gone very blank. Anybody there? Seamus?
Yeah, I'm
wonderful.
sorry about that. I just got kicked out with the internet. It's a bit weak where I am. My question now, and I think we'll be looking at an awful lot of the health scrutiny later on in the autumn, but I'm thinking to myself that I should ask this now. In the event that there's a spike, which is possible, what areas of concern do you guys have in relation to the health world?
Again, if I try and start, and then colleagues may have additional points to make. I think we have a number of concerns. If I start sort of picking up a couple that have come in earlier questions, we are currently still trying to restore services to relatively normal levels, and any further increase in infections will clearly push that back by some distance, and as I've highlighted, we are already concerned that there are patients out there with serious symptoms in need of assessment, potential diagnosis and treatment who are not coming forward now. So we would be all the more concerned for those patients. I think secondly, I would be very concerned around staff capacity, not just physical numbers of staff, but staff resilience. Staff are in the main quite tired at the moment, and I think we've heard that across the different presentations. So the longer time we can have to get people to recharge their batteries before having to go back into the fray, the less I would be worried around that aspect of it. The third thing that would concern me at the moment is that we are still at the beginning of our understanding of this illness. And I think we can all see that playing through as policy shifts and changes. And again, the more time we have to study and learn from the international experience of this, the better we'll be able to respond. And then I think the last thing I would flag, and it may sound, it may not sound like a health response, but I think it is we are just as much as anyone else desperately worried about the long-term economic damage that this illness is doing, and we recognise that inequality and economic deprivation have massive impacts on people's health and well-being. So what we are, as all services are, trying to walk that balance day by day between encouraging people to get back to work and participate in normal social and economic activity commensurate with their risk and their ability to socially distance and so on. But we really do recognise the very profound long-term damage that the economic challenges of COVID are likely to be placing on services for a long time to come, and that's right the way kind of across the board. I was talking with colleagues yesterday and GP colleagues who were flagging seeing patients with gambling problems and debt problems already coming through in higher number. So it's, you know, it's there and it's live now. So I don't know if that kind of is what you were thinking about, or whether there are other avenues.
No, that's fine. It answers the question. I think it sets a scene for us that when we're looking at things in the autumn, it will give us an idea what topics we should be actually looking at. And I think we'll hear a summing up later on from Natalie. I don't know if Keith wanted to say anything.
Yeah, I thank you. The bit I'd probably add to that is our concern around the actual impact of social isolation, if there was another period of lockdown, and what that means for individuals, and the increased anxiety that brings, and the anxiety about COVID itself. I think earlier speakers have talked about increases in terms of domestic abuse, and we've got some real concern around that. And I know our social workers have run some very successful and very well received webinars for professionals around that. But I think we would be concerned around that, and just the increase in high risk behaviours that people who are known to us might experience because of this prolonged period. And we're also starting to see people who've never accessed services before. So we know that there is an impact around COVID, around isolation, around the lockdown that's going to feed through. So I think a second surge will just compound that further.
Thank you.
Excellent. Thank you very much. Well, a good broad series of questions. I'm going to draw the questioning to a halt there because we're fast approaching 1 o'clock. And apologies to those of you who weren't able to get your questions in on that occasion. This is the point in the day where we retire as our respective joint committee to look at taking items forward for scrutiny. But before we get to that, can I just pass the joint committee's thanks on to all the contributors today, and as we know they're listening. Thanks Jane, Sian, Keith, and Karen for their extended input this morning. Very, very helpful. So we're in the hands now for the moment of officers from Democratic Services who, I don't know if they're going to take us into another room or just confirm that we are now formed up as a committee.
David, could I just come in to do a quick summary of the health issues?
Yes, please. But are we now we're now meeting as our joint scrutiny committee. Now, bear in mind that Health Scrutiny will have their thoughts, and Overview and Scrutiny will have other thoughts. So I'm looking to Natalie and Fiona to help us through that. Thank you, Natalie.
I just think it would be helpful to run through health while all members are here, because I think that members of both committees would recognise a lot of the comments that were being made by NHS colleagues. For instance, the recognition of the hard work of staff throughout the system and how well those partnerships have borne up, including voluntary sector and volunteers. Also that, again, as with HCC staff, that staff have had to adapt to very changed working conditions, sometimes at pace, and actually moving into areas in which they're less familiar. Some of the key things that have helped the NHS, again back to HCC, has been that support from the system, making decisions quickly as to how that support can be utilised across the system. And again, hearing about concerns about the impact on staff in terms of fatigue, burnout, and greater resilience. Staff have responded great. They've come up with innovative ways of doing things. And I think that is something that Scrutiny could usefully look at for both HCC and NHS services. You got assurance from HPFT that the self-assessment and the self-assessed risk assessments were particularly welcome by BME staff. You heard that certain initiatives that have been introduced will continue during beyond COVID, which is the HPFT A&E division diversion will become permanent, and the 24/7 helpline that's available for patients and staff across the health and social care systems. You heard great working with public health, which I don't imagine will stop anytime soon, because I think that there is the preparedness for any second wave, but also some of the joint ways of working have been extremely productive and is actually fundamental to the success of the integrated care system. So that is really welcome news. Also, that you heard HPFT identifying that trauma, PMTADS and anxiety, sometimes due to fear of COVID itself or economic impacts, is something that they're expecting to come across their radar pretty soon. And also, again, something that Jane mentioned was people presenting who are more unwell than you would have expected, possibly because they've taken the fear of COVID in terms of going into a health setting to heart and don't want to jeopardise themselves further, or in protecting the NHS, they've not gone to the GP and been identified as a case that should be taken forward. I thought that in terms of any preparedness for second wave was a concern that messaging is stopping patients with serious problems presenting themselves, and I do think that's something that HSC may wish to give consideration to, and also communications, making sure that people don't sit at home too long worrying about their health. They get off to the GP to get themselves diagnosed properly, but also something around the comms for how GPs and primary care are equipping themselves to message members of the community effectively in terms of, yes, we're open, and you will receive a positive response should you need to get in touch with them. I think that Nigel made a good point in terms of data, that the data that's been suspended being shared more broadly would be helpful in terms of helping everybody understand what the implications of a second wave or even preparing for winter pressures would be helpful. And I thought that the final segment that both HPFT and ICS came up with was the longer that services have, and again this is true for HCC, the longer that services have in restoring services to something like previous patterns, that will enable the backlogs to be addressed and unwell or vulnerable people to be cared for. Staff, I think, is going to be an issue that you may wish to pick up across both committees or individually. Staff, not just in terms of the numbers of staff available, but actually their resilience and ability to deal with winter pressures, etc. And a lack of understanding about what COVID is really like is making it extremely difficult to do that longer or even medium-term planning for both social care and health, knowing quite what services to have in place and which skill set's going to be the most imperative for that. Something that I think is hugely important is that long-term economic impact in terms of widening inequalities, impact disproportionate on deprived communities, etc. Point well made, which reiterated comments from Ian around adult care services, was the impact of more social isolation, anxiety, fear of COVID, impacts that they may have within family settings in terms of vulnerable children, domestic abuse, should we be experiencing any local or national lockdowns over the winter and spring, and a rise in high risk behaviours, and also the fact that services are seeing people that were previously unknown to them, so that's an increased demand beyond what might have been expected. I think all of those feed into those concerns that were shared with members before the committee, and I mentioned those at the beginning, and they still seem to be extremely pertinent. Issues around equalities for both committees to consider, issues around second wave preparedness and impact to consider, clearly a significant economic consequence to COVID and how we recover from that and provide employment, etc., for younger people. So economic is an issue to consider. and backlog and increased demands, on how those might be managed. Those absolutely stand, and all the evidence that you've received today, I think, contribute to those being 4 of the key areas for both committees to consider. Both committees have possibly got items already on their existing work programmes which you could consider refocusing to actually pick up some of these issues, such as people strategy could be refocused to look at redeployment, staff wellbeing. Public health outcomes could be refocused to look at what the joint response to COVID has been across HCC, but also between HCC and district and boroughs, and potentially widening that out to the NHS. Impact of the growth agenda, looking specifically through the COVID lens of economic impacts, where the LEP fits into this, employment prospects and the impact on younger people. Drug and alcohol services are on the work programme already, and you heard from Jim and children's services around concerns around substance misuse, self-medication also being mentioned by HPFT. So there are a number of things that you could rework quite easily, and that would enable us to do some really significant and important scrutiny over the autumn. But now what we need to do is to move into agree. The committees almost they don't need to physically separate, but you do need to separate yourselves into OSC and HSC, because it is only those respective committees that can agree to add an item to its work programme. And obviously Fiona and I will step in to assist if it isn't clear whether a specific issue belongs to OSC or HSC. I'm going to finish there, David, and pass back to you.
Thank you. I'm just going to pass over to Fiona for a very quick update on the resources element. Fiona.
Yeah, thank you. So yeah, just very quickly, I think we had the really positive, again, a positive story of partnership working across a really wide range of broad range of partners with the Operation Hypnos, and the IT rollout of Microsoft Teams, being really successful and fortunately really well timed. Also, I just want to draw out another really good, I thought was a good point just to kind of acknowledge, was the fact the work that legal and democratic services have done to make sure that councillors and council meetings and committees have still been able to continue over this period, and just just recognising the importance of good governance and accountability, possibly even more than this when decisions have to be made quickly and so much is at stake. Staff wellbeing and support, that clearly is an important priority that came through in discussion and will be obviously important to ensure resilience and staff readiness for future peaks. And the other really major factor was obviously the budget and the impact of COVID, and just acknowledging the current uncertainty around that, but clearly members of scrutiny committees are going to want to be regularly updated about that situation, and we'll look at the best way that we can scrutinise the budget this year and future years. The volunteer effort and how that can be utilised to benefit Herts citizens in the long term, after the pandemic, which and one more final point that I thought was very important was the commitment, the council's commitment to environmental sustainability in terms of recovery from the pandemic, and ensuring that's kept at the forefront, which seemed to be another important factor for members. That's all I wanted to add. Thank you.
Thank you very much, Fiona. Thank you, and thank you, Natalie. Right, Natalie, can you work with us now to guide us through this, so that we make sure we get the right headings in the right committee?
I suppose my first question would be whether members recognised the points that I was making around the four big concerns. If members are recognising that, I think it then becomes easier to slot a number of the issues that were raised during the committee debate, and also I've noted that have been appearing in the chat.
Yeah, there's a lot in the chat that we can pick up on. There's some very good stuff in the chat, in fact, and I'd encourage us to reflect on that. The challenge we have now is, by my reckoning, we're very nearly a quarter of an hour over past high time. But I do obviously want to bring this to a close in the most effective way possible. Seamus, I can see you. Are you looking to make a contribution?
I think, David, I think what we should do now is reflect on what we've heard this morning.
Yeah.
Natalie and Fiona then can circulate round to the whole committee, joint committees, their thoughts, and try and get an agreement via the email, hopefully, without too much discussion on it, so we can get it done fairly quickly while it's all fresh in our heads. I actually feel that would be the best way forward. Trying to do it now on the hoof is very, very difficult, and I don't really feel that we should sort of suspend the meeting now and go into a room ourselves and spend an hour or two trying to sort all this out and get the right effects, right words done. I actually think we need a bit of time to think on it.
I think you're absolutely right, and this has been my thought process. But can I go to Democratic Services and ask for a bit of advice there as to whether it's appropriate to continue offline in the way that Seamus has suggested, or whether we adjourn this and reconvene at some stage in the not too distant future to actually consider the recommendations that come forward. Can I have some advice on that, please?
Hi, Seamus, David, Michelle.
Hello. Hi, Michelle.
That would be fine if Natalie and Fiona can circulate the options of scrutiny. They'll keep me kept in the loop, and I'll pick up the recommendations for the minutes from that.
Thank you. Okay, well, that's very helpful, because I do want to keep this very much in the public domain. I don't want too many emails flying around in the background. I want it all to be there out so that we can, all members of the public and residents can see the work we're doing and reflect on it and contribute if needs must. So I think that's where we will go with this. So we'll park that for the moment, item 3, move on to item 4. There is no other part 1 business that I'm aware of. Natalie, what is your thinking about item 5, report to the County Council? Given that we're probably not going to be able to report anything from this because we won't have the conclusions ready.
I don't think you'll be able to report anything to the next County Council, and I think that what comes out of the deliberations and confirmation of this meeting's debates will go to a future one. Just need to make sure that you've got the agreement of both of your committees to that approach, and then we should be able to get on with doing the next stage and get that out to everybody.
Indeed. Okay. So, Michelle, are you there?
Yeah.
Okay. Are you ready to set up a vote? The proposal I'm putting to members of both committees is that we adjourn the proceedings, having gathered the evidence, in order that officers can go away and prepare recommendations to bring to this committee, this joint committee, at a date not in the too distant future, so we can formally consider those recommendations, discuss them, amend if necessary, and agree. Could you indicate your acceptance of that, please? Those of you that are present in the chat. Thank you, Dave.
Oh, right, in the chat.
In the chat, please. Thank you, Francis. Thank you, Lynn.
Can I just clarify?
Tina, yeah. Okay. Yes, please.
Are you suggesting that we have a further Teams meeting to conclude this?
Yes.
Fine. In that case, 4.
Thank you. Sorry, I've absolutely. I want to keep all of this on the table where everybody can see it. It's the most important piece of work we've done for a while, and probably like to do for some while yet. We've got to get this. We've got to get this right. Well, I'm not counting the numbers, but I'm not seeing any dissent.
Majority agreed, David.
Majority have agreed. Okay, thank you very much for that. Thank you for your support. You can see the notes of the next meeting. I won't bore you with that. Just if I may, at this stage, formally, I'll come back to you, Margaret, formally thank the contributors. It's been a very, very wide-ranging session, both in way of evidence offered and questions. Impressive use of the technology. Thank you all very much for supporting that. What I've picked up for this is just how proactive everybody involved in this COVID from every attitude has been. Before I go over to Margaret, can I just at this stage say it's been a bit like a swan today. Hopefully it's looked relatively calm up front, but there's been a lot of paddling under the surface. It remains to thank all the officers that have supported this process. It's difficult to underestimate the work's gone on. This has been a very complex thing to prepare for and to arrange, and indeed carry out. We've got lots and lots of important work to consider. Thank you to Democratic Services. Thank you to our scrutiny officers. Thank you to you, the members, who have contributed to this and given up a great deal of your time. Thank you very much. Margaret. That's the way we like you, muted. Go on.
I got totally cut off earlier, unfortunately.
No,
my internet went totally down in the middle of Jim's answer to me.
We missed you. We missed you.
I just think that we do need to sort the date or approximately when you're aiming at a date for this new Teams meeting. I do agree that it will be good to do it at another time because it's been a long meeting. But I also was just going to point out that Nigel's just done a list which I think is very helpful.
Yes, we've seen that. Yeah.
With a slightly different emphasis than the reports have, because they are highlighting the issues that people have anxiety about. And I think it's a very helpful highlight list.
Yeah, there is. Officers have captured, we have been capturing it, the chat on the way through. There's been a great deal of good stuff in there. I did ask officers not to respond in the chat because it was getting rather complicated, but you make a valid point. There's a lot of stuff there. Lots of people have contributed. Apologies to those that I couldn't bring in. I think everybody that wanted to ask a question got something in. But Margaret, I'm going to stop you there because
does the chat get saved? I was going to say because
it's a record. It's a record now. It's a public record, so it's there.
Yeah, no. What I mean is, I actually put a question with some.
You did, yes.
Trying to solve part of the health inequalities, and there are some unanswered questions, partly because we haven't.
But it's in there. It's in there, Margaret. It'll be dealt with.
Yep, that's fine.
Margaret, I think it's fair to say, David, that if anyone has got any question about what came up here today, any of the topics that came up, or any elaborations they need, they should actually address that to the officers directly, rather than the NHS. But you should just do it through the officers. If it's an NHS question that you still want to have covered, send it to Natalie and she'll arrange to see it gets to the appropriate person. But it's right that you just actually do that via the officers, so that you don't so that we can concentrate on the big picture rather than just drilling into one or two little rabbit holes.
It was a joined up thing, actually.
Yes, I know, but you know, officers will answer you.
Yeah. Okay. Well, on that basis, now I'm going to ask officers to go away, work through the recommendations. They will work together. They'll come forward. I suggest in the first instance, come back to Seamus and I to discuss when we might resume this session. In the meantime, my thanks to everybody. My thanks to the members, your patience, your cogent questions, and your support through this challenging meeting. But I think we are definitely going to get some profit out of it. So once again, thank you very much. I'm closing the meeting by my watch at 13:21. Thank you very much.